I'm Dr. Fakir Abadi, and this is Human Immunodeficiency Virus in Adults, Part 1. Nobody knows the exact origin of HIV virus, but it probably spread from non-human primates to humans in the 1900s. If you don't treat HIV, an infected person typically progresses to death over a period of 10 years. So it's a very deadly disease. And it primarily affects men who have sex with men, which we call MSM, people who inject drugs, people in prisons and closed settings, sex workers, transgender people, and of course infants of HIV positive mothers. Now it is important to keep in mind that HIV is not transmitted by air or water, by saliva, sweat, tears, or closed mouth kissing, insects or pets, or sharing toilet food or drinks. Another important thing to keep in mind is that women have been historically underrepresented in clinical studies. This is an important thing to point out in Journal Club. And in the US, about 25% of HIV infected patients are women. Now let's take a look at the HIV prevalence worldwide in the United States and in California. So in the left-hand side, we can see a figure of prevalence of HIV worldwide. So on the y-axis, we are looking at the number of cases, millions of people. So there are 39 millions of people worldwide living with HIV. And when you compare it with some of the other conditions, you can see 58 million people live with Hep C virus, whereas 296 million with Hep B, and 463 million people with type 2 diabetes. In the United States, about 1.2 million people live with HIV, 2.4 million with Hep C, and 2.2 million with Hep B, whereas 37 million people with type 2 diabetes. And in California, those numbers are about 140. Now, these numbers are in thousands of people. So 140,000 people live with HIV, 320 with Hep C, and about 4 million people with diabetes. So in general, you are more likely to encounter patients with diabetes in the clinic than you are to see patients with HIV or Hep C, unless you are working in HIV clinic or immunosuppressive clinic. Now here in the right hand side, I have listed the top 11 counties with HIV, with the highest HIV prevalence. So LA County, San Diego County, and San Francisco County are in the top 3 with the highest prevalence of HIV cases. Now, when we look at new HIV diagnoses in the United States, you will see that 2/3 of the cases are in men having sex with men, so MSM, either gay or bisexual, followed by about 23% in heterosexual individuals and about 7% in people who inject drugs. And of course, as a result of this, majority of cases, about 81%, are in men. Now, on the left, you will see that majority of cases are in minority. So the top 3 bars are minority MSM, followed by minority heterosexual individuals. And I'm not showing you the data for age groups, but recently there has been the highest number of HIV diagnoses in people aged 25 to 34 years of age. Now let's take a look at the HIV virus itself. The HIV virus is a retrovirus, and a unique capability of it is that it's able to integrate its DNA into the host genome. Now, generally speaking, there is HIV-1 and HIV-2. In the United States, it's predominantly HIV-1, whereas in most of Africa, you will see HIV-2, which is not common in the United States. Now, HIV-1 itself has different groups. Group M happens to be the major group of HIV-1, and Group M itself will be broken into several clades. So there's clade A, B, C, etc. And when you compare HIV-1 to HIV-2, HIV-1 is more prevalent and also more pathogenic than HIV-2. Now let's take a look at the structure of the virus. So you can see that the genetic content of the virus actually codes for several proteins. And these proteins, so this at the top is just the genome of the HIV. So different genes will code for different proteins, and every protein has a crucial function for the virus. So in the structure, you can see that there are some proteins that are structural proteins, like envelope proteins. So they have a very important function when it comes to cell entry. So these proteins need to bind to the host cell. And also there are a few enzymatic proteins. So for example, one of the important ones is the RT or reverse transcriptase. There's also integrase, and there's also protease. So reverse transcriptase, integrase, and protease are three of the most important enzymes of the HIV, and we actually target them with drugs. So it's important to know because the mechanism of action of some of our antiretrovirals is actually based on this. The first learning objective is describe the HIV life cycle and the mechanism of action of antiretroviral agents. HIV virus primarily affects the CD4 T cells. So CD4 T helper cells are a very important part of the immune system in the human body. So let's start here. When the virus finds a CD4 T cell, the first thing it does is that it's going to attach to the CD4 receptor. So some of those envelope proteins, they actually detect the CD4 receptor. And this process is called attachment, and we also have drugs, some drugs that will inhibit the attachment, called attachment inhibitors. Now, the binding of these envelope proteins to the CD4 receptor alone is not sufficient for cell entry. So the virus also requires co-receptors. And these co-receptors are either CCR5 or CXCR4. And this depends on the virus. So some viruses prefer CCR5 and some viruses prefer CXCR4. And this is referred to as tropism. So once the virus binds to the CD4 receptor and the co-receptor together, then the virus will actually be able to fuse and enter the cell. This process is called fusion, and we also have some drugs that block this process, referred to as fusion inhibitors. Once the virus fuses, the content of the virus will go inside the cell. So inside we have genetic material, and we have some of those enzymes that came with the virus. So for example, reverse transcriptase is one of the important ones. And if you guys remember from the central dogma of molecular biology, the process of transcription is typically from DNA transcribing into RNA. And the reason this enzyme is called reverse transcriptase is because the material that comes with the HIV is actually in RNA form, and reverse transcriptase will convert that RNA into DNA. So it goes from RNA to DNA. So it's in reverse. And what this enzyme reverse transcriptase does is that it will use nucleotide. So natural nucleotide that are in the host cell will be utilized in order to form this DNA. So we can actually target this with two classes of drugs. One class is the nucleotide analog reverse transcriptase inhibitors. So these are basically drugs that kind of look like natural nucleotides. So the reverse transcriptase will accidentally use them and insert them into this DNA. But because they're not natural nucleotides, they won't be able to make links, and then it will interrupt the transcription. So we can have nucleotide reverse transcriptase, or NUCs for short. Another class is non-nucleotide reverse transcriptase inhibitors. These are not necessarily analogs of nucleotides, but these are molecules that actually have affinity for the reverse transcriptase. So by binding to reverse transcriptase, they will actually inhibit its function. So these are called non-nucleotide reverse transcriptase inhibitors, or non-NUCs for short. And then once this DNA is made, then it will go inside the nucleus of the host. And then another enzyme that came with the virus is integrase. And what integrase does is that it will actually integrate this new DNA from the HIV and will integrate it into the host DNA. And by doing that, it will actually make the HIV genetic material as part of the host DNA. And that's why, it's we don't currently have a cure for HIV because its material actually gets integrated into the host DNA. Now, once this material is integrated into the host DNA, the virus doesn't have to do anything. Now, the central machinery of the host cell will actually transcribe this DNA material into RNA, and then this RNA will go and find a ribosome and translate into proteins. So, these are genes from the host as well as any gene from the HIV. So if it happens to be HIV genes here, the end product is those proteins that are required for HIV. So for example, reverse transcriptase will be made here, integrase will be made here, protease will be made here, and those envelope proteins, they will all be here, made here, and then they all assemble into a new virus which will bud and exit the cell. Now, once this new virus exits the cell, it's not mature at the beginning. So that's where protease will come in. Protease is very important for the virus because it will actually have the function of maturing that cell. So without that protease, that new HIV virus will not be able to infect other cells. So for it to become mature and then be able to infect other cells, it needs the function of protease. And because of that, we actually have a class of drugs called protease inhibitors, specifically HIV protease inhibitors that will block this process. And these HIV protease inhibitors are different than hepatitis C protease inhibitor. So do not confuse these two different classes of protease inhibitors. Let's take a look at the pathogenesis of HIV. As you know by now, the primary route of transmission is by sexual contact. So if it's through vaginal sex, you can see that this is the mucosal layer of the vagina, so the virus can easily penetrate through this layer and enter the body. Or if it's men having sex with men, in the rectal tissue, there are dendritic cells that actually have the function of surveying the system, and this dendritic cell will actually pick up the virus to hand it to the immune system to get rid of. So regardless of which route, the virus will end up in the body and will find a CD4 T cell. It can also infect macrophages, but the primary route is through CD4. And the reason it's really important to focus on the CD4 because CD4 T cells typically are either activated or in a resting phase. When a CD4 T cell is activated, that means the cell is actually converting the genetic material into protein, whereas in the resting CD4 T cell, it's actually silent, so it's not really producing any proteins from the genetic material. And the HIV can actually infect all of them. So the reason this is important is when HIV is integrated into DNA of a resting CD4 T cell, it's hard to detect it because the virus is actually inside the DNA, and because it's not actually being converted into any protein, there are no antigens, or there are no antigens to be detected by the immune system. Whereas in an activated CD4 T cell, because of these end products, the immune system can actually detect it. It can basically kill the CD4 T cells and also cause inflammation. But because of these resting CD4 T cells, whatever HIV is in there, it will actually be archived and stay in the body of the host without the body being able to get rid of. So basically, these resting CD4 cells will act as a reservoir for the HIV material. So even though the immune system continues to fight all the infected cells, and it will continue to kill the infected cells, whether they are macrophages or the activated CD4 T cells, those latently infected CD4 T cell will continue to be there, and occasionally they become active, but they so the body can never completely get rid of them. So two things happen. As these CD4 T cells get activated, the immune system will kill them. So because of the destruction of these CD4 T cells, the CD4 T cell count will actually start to drop because some of them are dying. Another thing that happens because of the inflammation and all this immune response is that the lymphatic tissue that's responsible for making these CD4 T cells starts to die because of the inflammation and the response of them. So because of this, we get decreased production of the CD4 cells. So there are two reasons for why HIV infected patients start to have low CD4 counts. That's because of increased destruction of the activated ones and also decreased production. So this is a progressive disease. As patients get infected, there's acute HIV infection, which initially the immune system starts to kill all of those activated CD4 cells and infected macrophages. And then there's a period of clinical latency where, there's not a whole lot of symptoms and a lot of these CD4 T cells are resting. And then over time, because of the CD4 cells count starts to drop, then the immune system will be weakened and eventually will be non-existent, and that's when the patient will have AIDS or acquired immunodeficiency syndrome. So not everyone infected with HIV has AIDS. It's only advanced HIV that we call AIDS, and by definition, it's, if the CD4 T cell count is less than 200, or if the CD4 T cell count is not available, then you can look at the percentage of the CD4. So if less than 14% of lymphocytes are CD4, this would be referred to as AIDS. Or even if someone has higher than 200 or higher than 14% CD4, but happens to get the AIDS-defining condition, then this will be classified as AIDS. And those AIDS-defining conditions are actually listed here for your reference. You can see that initially a normal person has over 1,000 cells of CD4 T cells. As you can see, initially during that acute phase where there's a high level of RNA, HIV RNA, the CD4 cell starts to drop very quickly. And then the immune system will take over, and then it will be, the CD4 starts to go back up. And then at some point you reach the set point where lymphatic tissue starts to die, and then the body cannot keep up with production of CD4. And as those resting CD4 cells become active, the immune system starts to kill them. So you can see that over a few years, the CD4 count starts to drop and drop and drop. And then once it goes less than 200, that's when really, we say that the patient has AIDS, and they start to get these opportunistic infections that will kill the patient. And not just infections, but also because the immune system has the function of surveying for cancer-forming cells and destroying them. As these CD4 cells can start, these patients are also at risk of getting various types of cancer. Now, when it comes to the symptoms, during the acute phase where where there's a surge of viral load, that's when patients start to have flu-like symptoms. So typically 2 to 6 weeks after primary infections. So, they're very similar to the common cold or the flu. And then, beyond that, the patients become asymptomatic until the infection actually advances. So the chronic phase is basically asymptomatic until the patient gets opportunistic infections. And then in, very advanced phases of the infection, you also see cardiovascular disease, cancer, and eventually death. Let's take a look at 4 classes of drugs that affect HIV cell entry. We have CD4 receptor antibody ibalizumab. Ibalizumab is a recombinant humanized monoclonal antibody, and it actually binds to the CD4 receptor on the T cell. So in this picture, you can see the CD4 receptor here, and thereby prevents conformational changes in the CD4 HIV envelope glycoprotein 120 that are essential for viral entry. So that's how it blocks entry of HIV-1 into CD4 cell and prevents its transmission via cell-cell fusion. Now, it's important to note that because this antibody binds to CD4 receptor, it actually does not interfere with the normal CD4 cell activity. So those CD4 T cells will still be functional. Next, we have CCR5 inhibitor Maraviroc, which basically binds to CCR5, which is one of the co-receptors required for cell entry, and it changes its conformation and prevents GP120 CCR5 binding. Next, we have enfuvirtide, which is a fusion inhibitor. It actually mimics the GP41 protein on the virus, and by doing so, it prevents fusion with the CD4 cell membrane. And more recently, we have a new drug on the market, fostemsavir, which is an attachment inhibitor. This one binds to GP120 and basically prevents HIV virus attachment to CD4 T cell. Now, you already know the mechanism of action of nukes and non-nukes, which basically interfere reverse transcriptase inside the cell. And lastly, you also know the mechanism of action of integrase inhibitor, which prevent integration of HIV genome into the host genome. And lastly, we have protease inhibitors, because once the cell cycle continues, these proteases are needed for maturation of the final HIV virion, and protease inhibitors actually block the maturation of the new HIV virions. Now, in December of 2022, the FDA approved lenacapavir, which is a unique antiretroviral agent because it has a multi-stage mechanism of action. So essentially, it is considered a capsid inhibitor. So it binds to two neighboring subunits of the HIV capsid protein. So the capsid is inside the envelope, and it essentially inhibits the capsid-mediated nuclear uptake of pre-integration complexes, so it prevents integration into the DNA. But also, if by the time the drug is taken, the HIV DNA has already been integrated, it can act by inhibiting virion production and proper capsid core formation. So it has three different mechanisms of action, and it is FDA approved in combination with other antiretroviral agents for treatment of highly treatment experienced patients who have multi-drug resistant HIV infection, failing their current ART due to resistance, intolerance, or safety consideration. So far, we described the HIV life cycle and the mechanism of action of antiretroviral agents. Now, given a treatment-naive HIV-1 patient, recommend DHHS guideline-concordant antiretroviral therapy. Let's take a look at some reliable resources. For HIV infection and anything that's associated with HIV, such as opportunistic infections, we use in the United States the DHHS guidelines. So the DHHS stands for the Department of Health and Human Services, and their guidelines actually updated at least a couple of times a year, and they are available online. So they have several guidelines. They have one for HIV-1 for use of antiretroviral agents in HIV-1 infected adults and adolescents. They have one for pregnancy. They also have a couple on pediatrics. The focus of this presentation is on adult in HIV. They also have a guideline for pre-exposure prophylaxis and a couple on post-exposure prophylaxis, along with CDC guidelines for diagnosis of HIV. Let's take a look at diagnosis of HIV. These are the recommendations from the 2014 CDC guidelines. Since 2014, it's been recommended to use an assay that's a combination of antigen antibody, and these are antigen and antibodies from both HIV-1 and HIV-2. And if this does not test positive, so if it's non-reactive, now assuming that the patient has not had a risky behavior in the previous 15 to 20 days, then we can confidently conclude that the patient does not have HIV. And this test has a very high sensitivity and specificity. It does take some time for the body to make antibodies and for the antigen levels to increase in the plasma levels. Therefore, if someone has just been exposed to HIV, this test is unlikely to detect it. Now, if someone does test positive, we don't know if it's HIV-1 or HIV-2. So therefore, we need to do another assay, which is an antibody differentiation, to figure out if this is HIV-1, HIV-2, or both. If antibodies for HIV-1 are detected but not HIV-2, we can conclude that the patient has HIV-1. If the antibodies for HIV-1 are negative but HIV-2 is positive, we can conclude that the patient has HIV-2. If both of them are positive, then the patient actually is co-infected with HIV-1 and 2. And if neither of them test positive, now we have a problem, because initially the antigen antibody tested positive, but now we didn't find HIV-1 or 2. Now, to resolve this issue, we actually need to do nucleic acid test. A nucleic acid test is a lot more accurate because instead of antigen or antibody, it actually detects the HIV RNA. So if this tests positive, then we can conclude that the patient has HIV. And currently in the US, HIV-2 is not common. So the nucleic acid tests that are FDA approved are only for HIV-1. Now, if this patient does not test positive, we can conclude that the patient does not have HIV-1. And this is assuming that the patient did not have risky behavior in the past week. So it typically takes about 6 days for the RNA levels to go high enough for this test to actually detect it. This nucleic acid test is a qualitative test, so it basically tells you if the RNA is there or not. Regardless, when someone is tested positive, we actually need to do PCR in order to quantify the viral load. The primary reason that this algorithm exists is because these antigen antibody assays are actually more affordable than the nucleic acid test. So if you're using it for screening purposes, where majority of patients will actually be non-reactive, this is a more cost-effective way of screening people. And then people who test positive will actually end up with more tests and possibly nucleic acid tests, which are more expensive. Okay, let's take a look at HIV serology. So in this figure on the x-axis, we're looking at time in units of days after exposure to HIV. And you can see that the first few days, it's referred to as eclipse period. And it basically means that it takes a while for the HIV to replicate and actually become detectable. So what we basically use to detect HIV the soonest is the nucleic acid amplification test, which basically can detect it by day 6 to 8. Whereas within the first 5 days, it's going to be undetectable. And then between days 13 and 20 is when the P24 antigen can be detected, and depending on what source you look at, you will see different numbers. So some sources say 15 to 20 days, some say 13 to 20. It's clear that around 2 to 3 weeks after exposure is when this antigen will be detected. And then it will take significantly longer for the body to make antibodies, and then those antibody tests to be detected. Now, up to 38% of new HIV infections are transmitted by people who are unaware of their HIV status. So it is important to screen people who are at risk for HIV. In fact, the 2019 USPSTF recommendations for HIV screening includes all adolescents and adults aged 15 to 65 years. And then people who are younger or older, if they have increased risk of infection, should also be screened. And of course, all pregnant persons, including those who are present in labor or at delivery, whose HIV status is unknown, should be screened for HIV. So when should treatment be started in patients with HIV? Now, in the old days, it used to be that the recommendation was based on the CD4 count. So patients who had lower CD4 count, they were at higher risk of having opportunistic infections, cancer, and of course mortality. So and of course older HIV drugs were very toxic, so we would actually reserve it for more severe patients. But nowadays HIV drugs are very effective, they're very well tolerated, And we have clinical evidence that regardless of CD4 count, when we start treatment for HIV, we can actually reduce the rate of morbidity and the rate of mortality associated with HIV infection. And this mortality could be due to cardiovascular disease, it could be due to cancer, it could be due to opportunistic infection. So it actually can be significantly high. And HIV treatment can actually reduce these numbers significantly. And of course, the other issue is transmission, and we do have very good evidence that once we start treatment, HIV transmission will be significantly reduced. And this transmission could be to sexual partners, as well as vertical transmission from infected mothers to the infant. Now, the December 2019 update of the DHHS guidelines recommend initiating ART immediately. So immediately means basically the same day that the patient is diagnosed with HIV, or as soon as possible after HIV diagnosis. And this is because it has been shown to increase uptake of ART and linkage to care, as well as achieving viral suppression faster in individuals and improve the rate of virologic suppression in patients with HIV. Now, when it comes to ART, it is very important to educate patients about the benefits and considerations of ART and to address strategies to optimize adherence. So we will talk about adherence shortly, but adherence is very important. So if there is concern about patients achieving being adherent to ART, then instead of starting ART immediately, it may be more reasonable to delay it a little bit, but do it as soon as possible. So as soon as the patient has access to care and the patient is ready to adhere to ART. Interrupting ART can lead to rebound viremia, worsening of immune function, and increased morbidity and mortality. So therefore, once ART is initiated, it has to be continued with the following goals. So the goal is to maximally and durably suppress HIV RNA in the plasma, to restore and preserve the immune function in HIV patients, to reduce HIV-associated morbidity and prolong the duration and quality of survival, and prevent HIV transmission. Now, it is common that once ART is initiated, because these regimens are very effective, that the patient can actually achieve a viral load reduction within the first 12 to 24 weeks of therapy. So within 12 to 24 weeks of initiating ART, the viral load should be undetectable. And recent data has shown that in patients who have a viral load of less than 200, so in general, less than 50 is considered undetectable. So even anything less than 200, studies have shown that the rate of transmission is basically non-existent. So now we say the slogan U equals U, so undetectable equals untransmittable. And this has serious consequences when it comes to the stigma that's associated with HIV. So we're starting a new culture of U equals U, because as long as a patient is taking their ART and the viral load is undetectable, then they cannot transmit it to their partner. Now, generally there are three different strategies for ART regimens. The historic strategy would be the triple therapy, which basically would include 2 NRTIs or 2 nukes as the backbone, plus a third agent. And the third agent can be either an integrase inhibitor or a protease inhibitor or a non-nuke. So 2 nukes plus a non-nuke. Now, in general, majority of integrase inhibitors are recommended first line. So that's why this one is green. And we'll talk more about specific agents shortly. We also have dual therapy. So dual therapy could be in 2 different ways. One is that you actually drop one of the NRTIs. And the reason we do combination therapy is that, HIV has a high propensity for developing resistance. So by using combination, we can basically prevent resistant development. So with the dual therapy, you basically drop one of the nukes. So you have 1 nuke plus an integrase inhibitor, which is, first line. You also have 1 nuke plus protease inhibitor, which is alternative. And we'll talk about specific regimens shortly. You also have NRTI free or nuke free dual therapy. So this is basically no nuke included in the regimen. So this is basically a combination of integrase inhibitor plus a non-nuke. And the reason this is red is because it is not recommended as initial treatment. It's recommended for people who already have received treatment from another ART and achieved undetectable viral load. Then they can switch to this strategy. Another non-nuke dual therapy includes integrase inhibitor plus protease inhibitor. Now, generally speaking, majority of first-line regimens that are recommended follow this rule that you need a backbone plus a third agent. So we use 2 nukes or 2 nucleotide reverse transcriptase inhibitors as a backbone plus a third agent. So it's important to have this combination in order to prevent HIV from developing resistance. And generally speaking, we have 3 backbones that are commonly used. So we have Epzicom, which is a combination of lamivudine and abacavir. We have Truvada, which is emtricitabine and tenofovir disoproxil fumarate. And we have Descovy, which is a combination of emtricitabine and tenofovir alafenamide. And I'll explain what's the difference between tenofovir disoproxil fumarate and tenofovir alafenamide shortly. Now, lamivudine and abacavir are 2 nukes that are commonly used in combination in Epzicom. So this would be 1 pill that would be used as a backbone. So if you are to use Epzicom as the backbone, you still need a third agent to go with it. Between lamivudine and abacavir, lamivudine also has activity against hepatitis B. Abacavir does not. So it's important to make sure that you are aware whether the patient also is co-infected with hepatitis B. Because, for example, if we are using something that covers hepatitis B and then later you decide to switch it to something that does not cover hepatitis B, the patient can have reactivation of Hep B and possibly Hep B flares, which could potentially be fatal. Now, all of these drugs in this class of NRTIs or nukes, because they actually are analogs of nucleic acids, that means that any RNA or DNA transcriptase can or polymerase can actually use this. So especially with the older NRTIs that we no longer use, they had an affinity for human mitochondrial DNA. And because of that, they were associated with lactic acidosis. And this became a black box warning, which, for the entire class. So these new drugs that we use, or I should say relatively newer, compared to the drugs from the 80s, these have lower affinity for mitochondrial DNA, and therefore they are not likely to cause lactic acidosis. But regardless, the FDA has this black box warning for all NRTIs. One thing that's specific with abacavir, before anybody can be started on abacavir, we should actually do a genomic polymorphism test of HLA-B 5701, and you should only start abacavir if someone tests negative for HLA-B 5701. And that's because people who test positive for HLA-B 5701 are at least they have a at least 50% increased risk of having fatal hypersensitivity reaction to this drug. So it's crucial to test this before starting abacavir. So that becomes one of the limitations of using abacavir, because you cannot. So if somebody tests HIV positive and you want to use this, you have to order this test, and it typically takes a few days, around a week, to come back. So it kind of delays therapy, but some patients may have no other option, so we have no choice but to test this, and then once they test negative, we can start a regimen that includes abacavir. Now, all NRTIs are renally cleared except abacavir. So abacavir is actually cleared hepatically, so you may need to dose adjust it in patients with mild hepatic dysfunction, whereas all other NRTIs actually need to be renally adjusted. So, for example, lamivudine, creatine kinase cutoff is 50. Now, as a class, all NRTIs can cause nausea, vomiting, headache, rash, and increased liver enzymes. Lamivudine specifically is very well tolerated in general, but it does, cause in some patients fatigue and insomnia. Abacavir, of course, can cause hypersensitivity reaction, especially if patients have HLA-B 5701. So HLA-B 5701 positivity is a contraindication, and of course it can also cause fatigue. Now, when it comes to the other combinations for the backbone, we have either Truvada or Descovy. So Truvada was their first, which is a combination of emtricitabine and tenofovir disoproxil fumarate. And these two combinations, both of them cover hepatitis B, and of course they still have this lactic acidosis black box warning, which all NRTIs do. And both of them are renally cleared, so creatine kinase cutoff of 50 for these two. TAF, or tenofovir alafenamide, is a newer formulation of tenofovir, which is actually creatine kinase cutoff is lower, so you can actually still use it in some patients with CKD. Generally speaking, these drugs are very well tolerated. Emtricitabine specifically can cause hyperpigmentation. TDF can cause nephrotoxicity and bone mineral loss, and this in fact is the reason that we actually came up with a new formulation of tenofovir alafenamide, which still does have nephrotoxicity and bone mineral loss, but it's significantly less compared to TDF, and I'll explain that more. Now, note that this tenofovir does not cause bone toxicity in the sense that it does not cause bone marrow suppression. It just causes some bone mineral loss. So this is not the same as bone mineral suppression. This just increases the risk of osteoporosis. Now let's take a look at the difference between TDF and TAF. So tenofovir itself is the actual drug. Tenofovir is the actual drug that's an analog of a nucleotide, and that's what needs to go inside the target cell to block HIV replication. The problem is when you orally take tenofovir, it's actually not absorbed. So this part is the GI tract, and when you take a pill of tenofovir, you would like it to be absorbed and go into the blood, and then the blood, in the circulation, HIV actually is inside the CD4 cell. So the target cell is the CD4 cell. That's where HIV replicates. You want this tenofovir to be absorbed into the blood, and then from the blood to go to the CD4 cell, and then find the HIV virus and block its replication. The problem is tenofovir is not absorbed. So we had to do something. We had to come up with some sort of salt formulations that increases absorption. And that's why we had TDF. So tenofovir disoproxil fumarate actually gets absorbed from the GI tract. So if you were to give 300 milligram, it gets absorbed. And then a tiny portion of what gets absorbed goes to the target cells, CD4. Okay, and that's how much we need in the CD4 in order to prevent replication of HIV. Now the problem is the majority of this tenofovir is staying in the plasma where we don't need it. And guess where it goes? It goes to the kidneys. It's gonna go to the kidneys and it's gonna cause nephrotoxicity. It's also gonna go to the bones and cause bone mineral loss, things that we do not like. So this has become a problem because patients need to be on these drugs for life, and over time this can build up, and patients will start to have CKD, or if they already have CKD, the CKD will progress. And as we all know, as we age, we also are all susceptible to bone mineral loss due to just aging, and this will actually accelerate it. So people who have HIV and are aging and are on TDF, they actually will lose more bone mineral. So we came up with TAF, which is a different salt form. So it actually absorbs. So when you take this orally in the GI tract, it gets absorbed. Now, majority of this goes into the target cell. So you get the same amount in the CD4 where you actually need it. And then a tiny portion of it stays in the blood where it's going to go to the kidneys and it's going to go to the bones and it's going to cause some toxicity. But because this is a significantly lower concentration in the blood than compared to TDF, it has significantly less nephrotoxicity and bone mineral loss. And therefore, we're starting to use more and more TAF compared to TDF because the efficacy is the same, because you get the exact same amount in the CD4 cell. And that's exactly why you see a huge difference in the dose. So TDF you need 300 milligram and TAF you need 25 milligram in most regimens, unless you have like a inhibitor where you would use a 10 milligram. So if you have cobicistat in the regimen, for example, you will see 10 milligram. So which regimen should be initiated for HIV patients? So these are recommendations from DHHS guidelines that were updated in 2021. So basically here we have all the regimens that include integrase inhibitors. You can see that anytime there is a slash, that means that multiple drugs are in the same tablet or they're co-formulated, so to speak. Whereas when you see a plus sign, that means there are two different formulations. So basically with this one, you will have to take 2 tablets. Now, having said that, let's take a look at recommendations. So green basically means recommended first line. So basically, a triple therapy with bictegravir as the third agent with the backbone of emtricitabine and tenofovir alafenamide. That's recommended first line. You can also have dolutegravir as the third agent, plus abacavir and lamivudine as the dual nuke backbone. Now with abacavir, it is important to note that there is a HLA-B 5701 test that must be performed, and it has to be negative before the patients can receive abacavir because of the risk of hypersensitivity, which can be fatal. Now with this regimen, only lamivudine is active against hepatitis B. So if someone is co-infected with HIV and hepatitis B, this regimen is not recommended because abacavir does not have activity against hep B. Next we have dolutegravir with a different backbone, so emtricitabine and tenofovir. Basically you can have Descovir or Truvada as the backbone. And lastly, more recently, we have the backbone of lamivudine plus tenofovir as a cheaper option. So these two formulations, Simduo and Temexes, these are recently available on the market as a cheaper option. So everything so far was a triple therapy. Then we have a dual therapy with a single nuke. So basically, this is the same as Triumeg. They basically dropped abacavir, so it's just dolutegravir plus lamivudine. So you basically don't have to wait for HLA-B 5701 because that becomes a barrier if you are to start ART when someone is newly diagnosed with HIV, because you have to wait for HLA-B 5701 test results to come back. So this takes care of that. So this is Dovato. And it's important to note that this Dovato can only be used if the RNA viral load is less than 500,000 copies per ml. And again, because you only have a single agent that's active against hepatitis B, it should not be used in patients who are co-infected with hepatitis B. Now, we used to have 2 more integrase inhibitors that used to be first line, but now they are considered alternative because we have so many other regimens that are actually easier for patients to take. So raltegravir, because you have to take it twice a day and it's 2 pills, it's not available as a single tablet regimen. So for that reason, it's considered alternative. And then we have elvitegravir boosted with cobicistat. So cobicistat is a pharmacokinetic booster with the backbone of emtricitabine and tenofovir. So although there are 4 drugs here, really there are 3. This is a triple therapy. you have two nukes and an integrase inhibitor. Cobicistat has no activity against HIV. It's just a pharmacokinetic booster. Now, this alternative is no longer first line. It used to be first line, and the reason is because of this pharmacokinetic booster. There are a lot of drug interactions, and this is a very large pill. So for that reason, it's no longer recommended first line because we have so many other options that work perfectly. And then we have a couple of non-nuke dual therapies. So one is dolutegravir plus a non-nuke, which is rilpivirine, and then cabotegravir, which was recently approved, plus rilpivirine. And the reason these are red because they are not recommended as initial therapy, because in order to use this, basically patients have to already receive another ART and achieve undetectable viral load, and only then they can switch to this regimen. So first, patients have to have undetectable viral load. So with Juluca, it has to be at least for 6 months, and the patient cannot have history of treatment failure or resistance. With cabotegravir, and this is actually rilpivirine. These are injectable combinations. So basically, this is to improve adherence because these are once a month injections. So basically, first the patient has to take a different ART and achieve undetectable viral load. And then for about a month, the patient will receive oral formulation of these two drugs just to make sure they can tolerate it. And then the patients will receive intramuscular injections of these two drugs on a monthly basis. And that has to be done in the doctor's office. Now, here are some other alternative regimens. So basically anything that includes protease inhibitors, they need to be boosted. And because protease inhibitors are boosted, they have a lot of drug interactions. And because we have so many other options available, these are considered alternative. Let's see. And then in the second section, we have non-nukes plus two nukes. So efavirenz basically is the non-nuke, and then you have two nukes as the backbone, emtricitabine and tenofovir. Efavirenz is no longer recommended first line. For the longest time, it used to be the drug of choice, and the reason is because of the high risk of suicide ideation and suicide attempt that has been shown with efavirenz. So for that reason, it's no longer first line because we have so many other options that are safer for patients. And then we have combination of rilpivirine is the non-nuke, and then we have two nukes as the backbone, emtricitabine and tenofovir. And this option is no longer first line because in order for rilpivirine to be effective, the viral load needs to be at baseline less than 100,000 copies, and the CD4 cell has to be greater than 200. So the studies have shown that when the viral load was greater than 100,000, or if the CD4 count was less than 200, those are more severe patients, and the outcomes were basically poor with this combination. In addition, rilpivirine needs an acidic environment for absorption, so that also complicates things. So we have so many other options that are, much better when it comes to adherence for the patients and efficacy and safety. So for that reason, it's no longer treatment of choice. It's considered alternative. And more recently, we have a new non-nuke, doravirine, that's come to the market in the past couple of years. It's available as a single tablet regimen with lamivudine and tenofovir. It's also available, as a single agent, so you can combine it with any backbone that you want. And this one essentially is right now is considered alternative because of the limited data. Overall, it has a much better safety profile. And it has a high barrier to resistance. So, if you have patients with HIV resistant to rilpivirine or efavirenz, potentially doravirine could maintain activity. And then regimens to consider when, people cannot take nukes, especially abacavir because of HLA-B 5701 positive test, or people who cannot take TDF or TAF because of whether they have kidney disease, advanced kidney disease, or if they have osteoporosis, these are regimens that do not include abacavir or tenofovir. So obviously Dovato, which basically has dolutegravir and lamivudine, is recommended first line. Whether people, whether the reason is for people who cannot tolerate this, or even if people can tolerate it, this might be a good idea to give people Dovato to avoid some of the toxicities from these agents. There is a risk of cardiovascular disease with abacavir, and of course nephrotoxicity and bone mineral density loss with tenofovir. So Dovato is an option, and then you have a couple other options in case somebody cannot take Dovato, which Dovato is actually, has been on the market in the past couple of years, so it's fairly new. We have older agents that basically combination of protease inhibitor boosted, of course, with either an integrase inhibitor raltegravir or with a single nuke lamivudine. And these are considered alternative because of the drug interactions that you will have to deal with ritonavir, and also raltegravir twice a day could potentially reduce adherence. We looked at the HIV life cycle and the mechanism of action of antiretroviral agents. We looked at the DHHS guideline recommendations for treatment-naive HIV patients. Now, given a newly diagnosed HIV patient, ensure adherence to ART is optimized. Let's take a look at some causes of treatment failure. It all starts with insufficient drug level. When there is insufficient drug level, HIV starts to replicate in the presence of drug, and that can lead to selective pressure. And selective pressure will basically select for strains of HIV that are resistant to the drugs, to the antiretroviral drugs. Of course, there's always the possibility that these resistant viruses could have actually been transmitted to the patient from someone else. So if someone else has resistant virus, and whether sexually or by other means of transmission, that resistant virus can also be in the patient. And resistant virus, of course, will lead to treatment failure. There's not much we can do to prevent the transmission of resistant virus from someone else, but we can do a lot of things to prevent insufficient drug level that will lead to resistant virus. As pharmacists, we should always check for drug interactions. So drug interactions, depending on the interaction, of course, can result to insufficient drug levels. Some drugs may be rapidly cleared, so it's important to make sure that the dose is adjusted when necessary. Poor absorption, so depending on the drug, whether it needs to be taken with food, the absorption of the drug could be affected, so that's important to keep in mind. And of course, there are some things that are out of your control, like host genetics. And sometimes the wrong dose may be given to the patient. So as pharmacists, we can ensure that the right dose is given. And historically, suboptimal potency of drugs was leading to some of this resistant virus. Nowadays, the drugs are very potent, so we don't really have that issue anymore. And of course, the biggest thing that results in insufficient drug level that we can intervene with are poor adherence. So poor adherence could be due to different causes. So one is social or personal issues. There is a lot of stigma with HIV. So, if someone is hiding the fact that they have HIV, this could actually prevent them from filling their prescription or actually taking their drugs in front of other people, such as friends and family. There could also be issues with a regimen. So, for example, if there is a pill burden, if the patient has to take multiple pills throughout the day, or if there are strict requirements for administering the drug. So for example, if somebody has to take it on empty stomach and they're eating all the time, that could be an issue. Or vice versa, if something, if a regimen needs to be taken with food, but someone is doing intermittent fasting, for example, that can cause a problem. And of course, toxicity. So sometimes, although most regimens nowadays are well tolerated, occasionally if somebody has some toxicities or some adverse effects of the drug, that they could actually stop taking it. For example, if somebody starts to have a rash or nausea, that could be a reason for people to stop taking their drugs. And adherence is extremely important. Now, this study was was published in 2000, so these numbers may actually be different today because our drugs are more potent. But what they looked at is that they looked at different percentage of adherence and looked at the percentage of patients that actually had virologic failure on the vertical axis. So you can see that when adherence was less than 70%, the HIV regimen basically became worthless because the failure became as high as 82% or even more. And you can see that around 90 to 94% adherence was really required to have high or less failure rate, and really 95%. And of course, those agents that were used here were less potent compared to what we have today. But regardless, it's recommended that adherence of 90 to 100% is necessary to achieve and maintain viral suppression. So it's very important to talk to patients to make sure that they're actually ready to adhere to these drugs, because this is a lifetime commitment. So we need to make sure they're ready for adherence before we actually initiate them, because once you initiate them, you do not want them to interrupt their regimen, because that will lead to selective pressure, which can lead to resistant viruses. So this 90 to 100% adherence is very crucial. And if you think about it, if somebody misses one pill a week, that's about 85 to 86% adherence. So even missing one pill a week is not enough. So they need to, they should not miss more than 2 pills a month. So 2 pills out of 28 days will result about 93% adherence. Now, how do you measure adherence? There's no gold standard for measuring adherence, but there are things that we can do. So if you actually get the viral load in the patient and it's suppressed or it's undetected, that's a very good indicator that the patient is actually taking it, so it's working. Studies have shown that patients self-report usually overestimates. However, if the patient actually reports that they're not adherent, that's a very good indicator of suboptimal therapeutic response. And one thing that we can do as pharmacists is to actually check pharmacy records. For example, if somebody had a 30-day supply and they haven't filled it for 3 months, that's a good indicator that they haven't been taking their medications. And you can actually occasionally do a pill count to make sure that they're actually taking it. Now, some factors that are associated with reduced adherence is, one is pill burden. So in general, if you can give the patients a single pill, that would improve adherence as opposed to multiple pills. One issue is low literacy. So if the patient cannot read the instructions that are on the label, that could lead to adherence. So for example, if you have a regimen that the patient needs to take twice a day, but they're taking it once a day, that's going to result in suboptimal exposure to the drug. So it's important to make sure that the patient understands how to take their medications. Younger age is associated with adherence failure, and usually because younger people are just not used to taking medications, so they may not know how to, or they may not remember to take it, whereas older people who already take drugs for hypertension, for example, they're more used to it, so they have the habit of going to their taking their medications daily. Some other challenges, especially in older patients, are polypharmacy. So if somebody has to go through 10 bottles, that's cumbersome. Some elderly have vision loss, so they may not be able to read the label even if they have the literacy, or they may not see where their medication is. And of course, as we all age, we'll have cognitive impairment, so they may be confused, they may not remember if they took it or not. They might think that they already took it, but they didn't, so that can lead to adherence issues. Other things include stigma, so some people may not want to have their friends know that they're taking this medication, so they may want to hide it. They may not have the opportunity to take it. Other psychosocial stresses, especially active drug use or alcoholism, can reduce adherence. So, if somebody's under the influence, they may not necessarily be, oh my God, it's time for me to take my pills. They may be doing other things and not be aware of it. Mental illness, of course, can lead to reduced adherence. And of course, medication adverse effects. So if somebody's experiencing these, they're less likely to want to continue to take it, especially if this is a lifetime commitment, which can result in treatment fatigue, because they have to keep taking this pill every day for the rest of their life. And occasionally, cost and access to the medication can be an issue. And of course, the opposite of those factors will improve adherence. So for example, if you simplify the regimen, once daily dosing, that can improve adherence. And when it comes to adherence, we as pharmacists have a key role. There are many things we can do to improve adherence at the pharmacy. Perhaps the most important intervention we can make is education, whether we provide education to other clinicians or education to the patient regarding the actual HIV infection, how to treat it, how to prevent it, how to prevent transmission, how to stay adherent to the regimen, how to follow up with their clinician, and individualize the regimen to the patients. And there are tools that we have at our disposal, such as pill boxes. Pill boxes are useful when someone has multiple pills to take, so they can, especially if the schedule is different. So if one pill is twice a day, another pill is once a day, you can easily set those up in a pill box. Whereas pill box might not be as useful if just a single drug once a day. If in fact pill boxes are large and they take space as compared to a single bottle. But if somebody has multiple bottles of pills, a pill box will be very valuable. There are dosing packets that we can use to make it easier for patients. And of course, because oftentimes patients forget to take their drugs, there are tools we can use to remind them. So there are telephone services that they can subscribe to. They can receive messages. And of course, with current technology, there are smart devices that you can use apps on. So including smartphones and other devices. You can also, if someone doesn't have a smart device, they can actually set an alarm on their watch. So when the alarm goes off, similar to some of the techniques that we tell patients to remember their birth control, basically. And of course, there are other tools that we can do to improve adherence. Now the question is, so if someone has adherence issues, we still need to treat them. So how are we going to approach it? So because adherence, as I explained, is going to lead to suboptimal exposure to the drug, and then selective pressure will lead to drug resistance, one thing we can do in patients who have adherence concerns is to actually use drugs that have a high genetic barrier to resistance. So we can use either dolutegravir or darunavir. So these darunavir is a protease inhibitor, and dolutegravir is a second generation integrase inhibitor. And these, because they have a high genetic barrier, are recommended in these patients, because if they miss a dose or two, these drugs are less likely to lead to resistance compared to other regimens. Now, it's not to say that these are 100% proof. It's just that these are less likely to select for resistance. And bictegravir is not in the guideline for this purpose. Bictegravir is also a second generation integrase inhibitor with a high genetic barrier. So as more information becomes available about bictegravir, that will potentially be an option as well. But as of right now, it's not in the guideline for this purpose specifically. We described the HIV life cycle and the mechanism of action of antiretroviral agents. We looked at DHHS guideline recommendations for treatment-naive HIV-1 patients. We ensured adherence to optimized ART in newly diagnosed HIV patients. Now, given an HIV patient, design an individualized monitoring plan. First, let's take a look at a few definitions. Viral suppression by definition is a HIV RNA level that is below the lower limit of detection of available assays. In clinical trial, usually this is considered a viral load less than 50 copies per ml. Virologic failure is any time where viral load is actually more than 200 copies per ml. Incomplete virologic response if the viral load is greater than 200 in 2 consecutive viral loads that are separated by 24 weeks. So if you get a single level that's greater than 200, it doesn't necessarily mean that it's a complete virologic response. You have to look at the trend. So it could be that the viral load is greater than 200, but it's trending down. So it's important to get a second one and to see if it's trending down or up. Virologic rebound is when a patient has virologic suppression, but then after virologic suppression, then the viral load becomes greater than 200 copies per ml. And a virologic blip is once the patient gets virologic suppression, then there's a single isolated detectable RNA level, and then the patient goes back to suppression. So this is a quick virologic blip. And of course, low-level viremia is if the virus is actually detected, so greater than 50, but actually less than 200. Let's take a look at what happens when we actually initiate ART. In an uninfected person who does not have HIV, a normal CD4 count is usually around 800 to 1200 cells per microliter or more. In HIV-infected patients, the CD4 count starts to drop. So for most patients, about 200 to 500. And of course, once CD4 count drops to less than 200, at that point, the patient has AIDS. Alternatively, if the percentage of lymphocytes that CD4 is 14% or less, that also constitutes AIDS. Now, once we initiate ART in the first month, so within 30 days, you should suspect a 2-log drop in viral load. So, for example, if, and of course, every log is you basically drop a 0. So if the viral load is 100,000, a 2-log drop would be you just take out 2 zeros out, so it would be 1,000. So you would expect the patient to go from 100,000 to 1,000 within the first month. And then 3 to 6 months, you should have undetectable viral load because the ARTs that we currently have on the market are highly effective. Now, when it comes to CD4, within the first year, it's expected that the patients will gain about 150 to 250 CD4 cells, and this levels off beyond 2 years, so this will not continue to go up to normal. So the goals of therapy is to have an undetectable viral load and to have CD4 count of at least 500. And that's because typically less than 500 is when opportunistic infections start to emerge, especially if it's less than 200. Let's take a look at monitoring parameters for HIV. So you can see, so green means that you basically need to get this laboratory parameter for everyone. And yellow means that for some patients, you also may need to do that. So at baseline, before we actually start ART, we need to check a viral load, CD4 count. We also need to check HIV resistance to make sure the regimens that we choose initially are actually working, because there's a possibility that the patient can get a resistant strain from somebody else. It's important to check for hepatitis B serology and for hepatitis C. Risk factors for getting HIV are similar to risk factors for getting Hep B and Hep C, so it's important to get these and treat these at the same time as HIV. Urinalysis is important for monitoring the renal function. So for example, you can measure the urine protein as well as urine glucose, which normally should not be in the urine, but people who have renal dysfunction will have glucose and potentially protein in the urine. So that's an easy way of monitoring renal function. And then for more comprehensive monitoring, a basic metabolic panel as well as liver chemistries and complete blood cell count are needed at baseline. And because HIV patients are at risk of cardiovascular disease, it's important to get a baseline fasting lipid panel and a fasting glucose or A1C, so that if these are abnormal, they get the appropriate treatment. And if you are to use abacavir, you need to get the HLA-B 5701. If you are not using abacavir, this is unneeded. And tropism test is only needed if the patient is to be started on maraviroc. So if the maraviroc is not needed, this test is unnecessary. And then 2 to 8 weeks after ART is initiated, it's important to get the HIV viral load. Now, if the patient's viral load is undetectable 2 to 8 weeks, then you can monitor it every 3 to 4 months. However, if the viral load is not undetectable 2 to 8 weeks, it's important to continue to monitor the viral load more frequently, so every 4 to 8 weeks until it's undetectable or at least is less than 200 copies per ml, and then you can switch to every 3 to 6 months. Now, for patients who actually have good adherence and they have suppressed viral load, you can actually make this easier and do it every 6 months. But that's only if the patient is adherent and the viral load at this point it was suppressed. So at the very least, the viral load needs to be monitored every 6 weeks. And if the patient's treatment fails, it's also important to check the viral load, and in fact, that's how you would know if the treatment is failing. And of course, situations were clinically indicated. For the CD4 count, once you start ART, it takes about 3 months for the CD4 cells to increase, so it's unnecessary to get one 2 to 8 weeks later. So typically, it's recommended to wait 3 to 6 months to get the CD4. And this is only needed if the patient's CD4 count was low or if the viral load is undetectable. Otherwise, if the CD4 count was already high, so greater than 300, and if the viral load is undetectable at 2 to 8 weeks, it's unnecessary to continue to monitor CD4 count because there will be no reason for the CD4 count to go any lower. Now, beyond 2 years, if the patient's CD4 count is still low, if the viral load is suppressed and they are adherent, you can actually make that easier and do it every 12 years or annually. And of course, anytime treatment fails, you should check viral load as well as the CD4 count, and if as clinically indicated. So clinically indicated, it just depends on the situation. You have to use your judgment because we couldn't possibly, or I should say, the guideline couldn't include every possible scenario. They just have the things that you should check as clinically indicated based on clinical judgment. HIV resistance is needed at baseline, but then you don't really need to do it unless the patient has treatment failure or you have some reason to believe that there is resistance. Otherwise, it's not really needed. The same with Hep B and Hep C, you definitely need it at baseline. If someone is at risk of getting Hep B or Hep C, or especially with Hep B, if they're unvaccinated, it's good to check these annually. Urinalysis that you need at baseline for renal function monitoring, you really need to get that every 6 months if someone is on tenofovir, so either TDF or TAF, because these are nephrotoxic. It's important to get urinalysis every 6 months. Otherwise, if someone is not on tenofovir, then you need urinalysis once a year or every 12 months, and if clinically indicated. For BMP and liver chemistries, you do get them at baseline and then 2 to 8 weeks just to make sure that the patient is tolerating the drugs, and then every 3 to 6 months just to make sure the drugs are not causing any toxicity. With the complete blood count, you do it at baseline, and then anytime that you need to get the CD4 count, for example, if you do need the CD4 count every 3 to 4 months, you also get the CBC. But at the very least, it's also recommended to get it every 6 months, and if clinically indicated. For the fasting lipid panel and glucose and A1C, you only need it annually, so at baseline and then every 12 months, unless if they were abnormal at baseline. So if someone's lipid panels was abnormal, you should do it twice a year. And the same with A1C. If A1C was abnormal or glucose, you should do it every 3 months. HLA-B 57, you really don't need to repeat it once you get it at baseline. And that's only if you need abacavir. So if abacavir is not in the picture, you never need the HLA-B 5701. Tropism, you only need it if someone is on Maraviroc. If the Maraviroc is not in the picture, you never need it. So if you are to use Maraviroc, you need it at baseline. And then if the patient has treatment failure, you need to recheck tropism, and if clinically needed. You can use Maraviroc if the tropism test shows CCR5, not CXCR4. We looked at the mechanism of action of antiretroviral agents and what DHHS guideline recommends for treatment of HIV patients. We ensured adherence to ART is optimized and designed an individualized monitoring plan. Now, given a prescription for antiretroviral agents, provide patient counseling for adverse effects. All right, let's take a look at the food requirements for these various antiretroviral regimens. For many of these regimens, there is no food requirement, meaning that the patients can take them with or without food. However, note that anytime you have elvitegravir, it needs to be taken with food, as well as anytime you have rilpivirine in the regimen. So, Odefsey and Complera have rilpivirine, so that requires food. Juluca also has rilpivirine, so because of the rilpivirine component, food is required. And also in general, protease inhibitors, darunavir and etazanavir, they require food. That's to improve absorption. Efavirenz is the opposite. So efavirenz should actually be taken on empty stomach. And again, even for efavirenz, food will increase absorption. But because there are such neuropsychiatric adverse effects with efavirenz, we actually want to minimize the absorption of efavirenz. So that's why it's recommended to take it on empty stomach. In fact, so much so that more recently, a new formulation of efavirenz came to the market with a lower dose, just to make it more tolerable for patients. Let's take a look at the safety profile of some of these combination regimens. So lamivudine is included in Epzicom, and it's generally well tolerated. As a nuke, it generally can cause, general headache, some GI issues, fatigue, insomnia, and some increases in liver chemistry, but nothing too serious, including rash. So in general, these are very mild and very well tolerated. Now, these are the newest nukes. Some of the oldest nukes that are no longer used, they used to have strong inhibition of DNA polymers in patients, which would lead to lactic acidosis. So because the mechanism of action is the same, you will see that lactic acidosis will listed in the package insert of any nukes, but the risk is very minimal. For abacavir, of course, there is a risk of fatal hypersensitivity syndrome, so it is important for patients to have a HLA-B 5701 allele. And this actually is 5 to 8% prevalent in Caucasian population. Symptoms of this hypersensitivity reaction includes fever, abdominal pain, and rash, and usually is within 2 weeks of starting abacavir. But because it can be fatal, if this occurs, it must be discontinued. Abacavir must be discontinued. Another issue with abacavir is that from observational study, some data have suggested that there is increased risk of MI. Now, there is mixed data on this, so it's not clear whether the risk is real or it's based on biased studies. But because we have so many other options available for patients who are at risk of cardiovascular disease, it's best to avoid abacavir because we have so many other options. Let's take a look at Truvada and Descovy. So tenofovir, in general, if this mnemonic helps, there is a NOF in tenofovir. So N for nephrotoxicity, O for osteotoxicity, and F for Fanconi syndrome, which is, basically wasting of electrolytes in the kidney. But Fanconi syndrome is very rare. Now, with osteotoxicity, it's important to note that this is actually talking about bone mineral density loss. It is not myelosuppression. Of course, TAF can reduce nephrotoxicity and osteotoxicity with tenofovir. And lastly, emtricitabine has this unique adverse effect of hyperpigmentation, in addition to GI adverse effects, as well as mild increase of liver chemistries. With Stribild and Genvoya, which include elbictegravir, they should be taken with food. Elbictegravir is generally well tolerated. One thing that may occur in up to 39% of patients, proteinuria. And the cobicistat component can actually cause a small increase in serum creatinine, which can actually artificially lower GFR. We'll talk more about that in a future lecture. Bictegravir does not need boosting, so it's a much smaller pill, so it's very easy to take. It's once a day single tablet regimen, and it's very well tolerated. Now, these are the formulations that include dolutegravir. So dolutegravir alone is Tivicay, and then with 2 nuc backbones is Triumeg, and then with a single nuc backbone is Dovato, and of course with a non-nuc, Juluca is dolutegravir plus a non-nuc rilpivirine. Now, in general, dolutegravir is well tolerated. One thing that may occur in some patients is insomnia, and also dolutegravir has been associated with weight gain. And in recent time, more data has emerged that this weight gain can be problematic, especially in patients who already have issues with pain management and are at risk of cardiovascular disease. One thing to note with Dovato, because it has a single agent against hepatitis B, there is a black box warning that if someone does have hepatitis B co-infection, there has been lamivudine resistant emerge. So that's important to screen patients for Hep B and make sure that the patients do not have Hep B co-infection when using this regimen. Isentress, which is raltegravir. This was one of the oldest integrase inhibitor. The issue is that you have to take it twice a day, so it makes it, challenging for adherence. And more recently, a higher dose, so HD is for higher dose, came to the market. So basically, you can do it once a day. But still, these are pretty much big pills, and the patients have to take 2 pills once a day. And one unique adverse effect of raltegravir is CPK elevation. So this is, if you remember from daptomycin, can also increase CPK. So that's something to keep an eye on with raltegravir as well. Next, we have Cabenuva, which is a combination of cabotegravir, which is an integrase strand transfer inhibitor, and rilpivirine. Now, this is the long-acting version of rilpivirine with a half-life of several weeks. Now, it's co-packaged. It's not co-formulated. It's co-packaged, meaning that there will be 2 vials in the package. So there is 1 vial for cabotegravir and 1 vial for rilpivirine, and the content of the package shows that they actually give you everything you need, including the syringes and the needles. These are intramuscular injections that are injected monthly, and most recently was also approved for injections every other month. And this is significant because of the monthly injections or every 2 months injection. It could potentially improve adherence, and also it can help with stigma. So if patients don't want to have a bottle of ART regimen laying around their home, and they can just get this injection. Now, it is injected into gluteal intramuscular, so it's not something that can be done at the community pharmacy. So they do need to go to their physicians or other appropriate settings to receive these intramuscular injections. Now, because of the very long half-life of these 2 agents, there is concern that, if you just inject it into somebody and they're going to have adverse effect, or if they don't tolerate it, the drug will be in their body for a very, very long time. So there was an optional, oral lead-in where you actually give the short-acting version of these drugs, which are PO, and then see if the patients can tolerate before they transition to the intramuscular injections. Initially, this oral lead-in was required, but more studies came out that they actually found that the injections are very tolerable, so it's really no concern. But that's something that can be discussed with the patient if they're not comfortable getting these long-acting agents in case they don't tolerate it. There's the option to give the oral version to see if they tolerate it, and the oral version is called Vocabria. Now, another thing about this regimen is that for patients who are treatment naive, they do need to have their viral load suppressed before they can get this drug, because there's only 2 agents in there. So essentially, they need to be on another ART regimen and have undetectable viral load before they can switch to this, to make sure that resistance doesn't occur. And that's for now. In the future, as more studies come out, that may change in the future. But currently, patients need to be treated on another regimen and have undetectable viral load before switching to Cabenuva. Now, anytime you have protease inhibitors, so darunavir and atazanavir, they have to be taken with food. Darunavir specifically, it's a sulfa drug, so we have discussed sulfa allergy before. It's not necessarily a contraindication, but something to be cautious, especially if you have so many other options. And someone has sulfa allergy, you can use something else, because adherence is extremely important. So the last thing you want is someone is having a reaction because of this sulfa reaction and they stop taking it. Now, with protease inhibitors, typically dyslipidemia can occur, so especially increased triglyceride and cholesterol. So that's something to keep an eye on, especially with HIV patients. HIV itself is a risk factor for cardiovascular disease. One more thing with atazanavir is that a unique adverse effect is unconjugated hyperbilirubinemia. So that's something to monitor when patients are on atazanavir. Which basically, some of the manifestations is, when they have hyperbilirubinemia, they can actually start to look, have a yellowish color. So, some clinicians call this bananavir, referring to the yellow color. But, given that we have so many other options, they're really not a good reason for people to be on atazanavir anymore. Relpeverin should also be taken with food. The non-nukes are only active against HIV-1. They don't have activity against HIV-2, which in general is not an issue, because HIV-1 is the most, by far the most common virus in the US. And, it can cause rash, hepatotoxicity, hyperlipidemia. So this also includes increased in triglyceride as well as increased LDL. And if patients were to overdose or achieve supratherapeutic concentration, it has relpeverin can also cause QTc prolongation. Efavirenz, of course, should be taken on empty stomach, because food increases its level to unsafe levels, and there are serious adverse effects, so including depression and suicidality, including people who attempted suicide. So it's a very serious adverse effect. So it's important that the patient take it on empty stomach, or if they already have psych issues at baseline. In general, it's best to avoid this regimen. But if there is no other option for the patient, the lower dose is an option. CNS side effects, occur in up to half of the patients, and basically they resolve after 2 to 4 weeks. So these are general CNS side effects, such as confusion, abnormal dreams, somnolence, impaired concentration, and occasionally severe depression. Now, one thing that also helps with abnormal dreams is if we tell the patient to take this at bedtime. Because if you take it in the morning or throughout the day, by the time it's bedtime, the drug is in the system and it can cause vivid dreams. And these dreams are, very problematic. Patients remember them, and, it can be very problematic. So one strategy is to, if someone develops vivid dreams, to take it at bedtime, because by the time the drug kicks in and you have sufficient concentrations in the blood, it's almost morning, so the patient is waking up, so there is less likely to be, those vivid abnormal dreams. And lastly, we have doravirine, which is also a non-nuc that was recently approved. And it, compared to other non-nuc, it has improved safety profile, including less neuropsychiatric side effects, as well as better lipid profile. In fact, it does not increase LDL and triglyceride, and it's also been shown to, if anything, it's going to reduce or lower LDL and triglyceride levels, and it may also, on the other hand, increase HDL levels. So, from a lipid profile, this drug seems pretty good, given that HIV patients are at risk of cardiovascular disease. The other advantage of this drug is higher barrier to resistance, including it, it has been shown to maintain its activity against viruses that are resistant to efavirenz or rilpivirine, for example. Currently, it's considered alternative because of limited data, so it's only been on the market for a couple of years. So, in time, it's likely that, either it becomes, first line, or, it might find its niche for patients who have developed to other non-nucs. This concludes this presentation. I'm Dr. Fakir Abari, and this is Human Immunodeficiency Virus in Adults, Part 2. Here are the reliable resources for HIV. In particular, we are going to cover clinical practice guidelines for pre-exposure prophylaxis, which were updated in 2021, just a few months ago. There are also guidelines for post-exposure prophylaxis, one for occupational post-exposure prophylaxis and one for non-occupational post-exposure prophylaxis, which are pretty similar, but we will only cover one of them in this course. The next learning objective is, given a patient at risk for exposure to HIV, recommend appropriate PrEP regimen. The 2021 guidelines for PrEP recommend that all sexually active patients should receive information about pre-exposure prophylaxis or PrEP. And of course, the ultimate goal of PrEP is to prevent the acquisition of HIV infection, along with its morbidity, mortality, and cost to individuals as well as society. PrEP is recommended for individuals who are at ongoing risk for HIV exposure, either from sexual behaviors or in individuals who inject drugs if they report injection practices that place them at risk. Now, one thing that is important is that acute and chronic HIV infection must be excluded by symptom history and HIV testing immediately before any pre-exposure prophylaxis regimen is prescribed. So let's take a look at how to exclude HIV. So clinicians should document a negative antibody test result within the 7 days before initiating PrEP. And this should be done ideally with an antigen antibody test. And it must be from the blood. So there should be a blood or serum sample. And it is preferred to have an antigen antibody test that's done in the laboratory. And that if that's not available, then a point of care antigen antibody test can be done still on the blood. Now, I emphasize that the sample needs to be from the blood because rapid tests that use oral fluids should not be used, specifically because they can be less sensitive than blood tests. So there would be high risk of false negative. The guidelines also state that clinicians should not accept patient-reported test results or documented anonymous test results. Now let's take a look at the algorithm that's in the guidelines. So this is for people who are not on pre-exposure prophylaxis or any prophylaxis, including post-exposure prophylaxis. So for someone who is about to be initiated for the first time on PrEP, the antibody antigen test is preferred from the blood. And then if the results are positive, of course, this is considered HIV positive, and then they will be excluded from being initiated on pre-exposure prophylaxis. And then if in fact this is confirmed to be a true positive, then they need to be transitioned into treatment of HIV. Now for individuals where they either test negative or if there is indeterminate test, the next thing to consider is if they have had HIV exposure in the past 4 weeks, and if they have signs and symptoms of HIV, acute HIV infection. If the answer is no, because the results are either negative or indeterminate, it's it's safe to assume the patient does not have HIV, and it will be safe for them to initiate PrEP. Now, if the answer to this question is yes, a second test needs to be done from the plasma to confirm the results. So this can be either another antibody antigen assay, or it could be an RNA assay, HIV-1 RNA assay. And of course, if either of these are positive, the patient is HIV positive. If either of them are negative, it would be HIV negative, and then the patient can be started on PrEP. Now for the RNA assay, the level that would be significant would be 200 copies per ml. So if the level is less than 200 copies, for example, if it's 150, it could potentially be a false positive. So it is recommended to get another level and find out, if that's a false positive or negative. But in general, if it's at least 200 copies or higher, it's considered a positive result. Now let's take a look at PrEP regimen. In general, there are 3 groups of individuals who can qualify to receive pre-exposure prophylaxis. The first group is men having sex with men or transgender women having sex with men. The second group is heterosexual men and women. And the last group is persons who inject drugs. Now, in general, we don't have enough data available for PrEP use in transgender men, so that's why they're not included in this chart. But for the largest group by far is MSM, or transgender women having sex with men. So we have 2 oral options available for this group. So either emtricitabine plus tenofovir disoproxil fumarate, so Truvada. This is once a day daily oral regimen, or the safer option, tenofovir alafenamide in combination with emtricitabine. This is also once a day oral regimen. So these 2 oral options are available for MSM, but for heterosexual men and women, as well as people who inject drugs, we only have Truvada once a day as an option. So Descovy has not been studied in these two groups. We also most recently have an injection regimen. So this is cabotegravir. That's intramuscular injection into gluteal muscle. So this is, it's not something that can be done at the community pharmacy. So it has to be done at the clinic by the physicians. This is a long-acting agent. So cabotegravir has a very long half-life. So the way the regimen works is that the first injection is done, and then the second injection is done 4 weeks later. But then thereafter, the injections are every 8 weeks. So this is intended to improve adherence, as well as people who do not want to take oral regimens daily. So, they just have to get 1 injection every 8 weeks. And this will be done by the clinicians. Now, it is important to note that you should not combine the oral and injectable. So patients receive either the IM injections, or they can get once a day oral options that I mentioned up here. And with the oral options, it's recommended to give patients no more than 90-day supply. That way they have to come back for the refill, and that makes sure that the patients receive their follow-up, so including HIV testing. Because we're not giving a full regimen, this is only 2 nukes that are used in PrEP. So, in case, this PrEP fails and the patient gets acute HIV, you don't want to have a regimen in those patients with only 2 nukes because that could lead to resistance. So it's important to check at least every 3 months, check for HIV. In case the patient tests positive for HIV, they need to be transitioned to a full ART treatment. Now, when considering who will qualify for receiving PrEP, of course, these are people, for these 2 groups, people who are sexually active, defined as having sex in the past 6 months, and they also have to be at risk of being exposed to HIV. So if they have any of these, so either HIV positive sexual partner, or if they had the bacterial sexually transmitted infection in the past 6 months, or if history of inconsistent or no condom use with sexual partners. And then for persons who inject drugs, to qualify for PrEP, they need to have either HIV positive injecting partner, or if they participate in sharing injection equipment such as needles, that will put them at ongoing risk, so they qualify for receiving PrEP. Now, before we can give these patients PrEP, it is important to document a negative HIV test that's been done in the past 7 days, as I mentioned before, and also to screen for acute HIV. So, that is to screen for any signs and symptoms of acute HIV. And of course, depending on what regimen it is, they must, of course, not have any contraindications. And for tenofovir, we know that renal function is important. So if somebody is getting a PrEP that includes TAF or tenofovir alafenamide, creatine kinase must be at least 30. And if it's tenofovir disoproxil fumarate, the creatine kinase has to be at least 60. Now, these cutoffs are specifically for PrEP, not for when you use these agents for actual treatment of HIV as part of ART. So there are different cutoffs for creatine kinase for full treatment, but for the purposes of PrEP, these are the cutoffs. So if somebody's creatine kinase is 40, for example, they cannot get TDF plus emtricitabine for PrEP, but they do qualify to get TAF plus emtricitabine. And there is no cutoff for cabotegravir. So cabotegravir is a integrase strand transfer inhibitor. It's not renally cleared. Now let's take a look at the options. So in general, efficacy of PrEP, either oral or injectable, it is dependent on adherence to ensure that plasma drug levels reach a protective level. It's important to note that the time from initiation of PrEP to maximum protection against HIV infection is unknown. So when somebody initiates these, it's not clear if they have the protection immediately or, a few days later. What we do know from pharmacokinetic studies, specifically from Truvada, is that, we get enough concentrations of Truvada in different sites. So it really depends on the site. So if it's, for example, people who inject drugs, the site of infection will be blood. So some sources say it will take 7 days, others say 20 days. So it's safe to assume that somewhere, in the first, it will probably take around 2 to 3 weeks before this pre-exposure prophylaxis is fully effective in preventing HIV infection through blood. And that's 20 days in cervical-vaginal tissue. So for women, this makes a woman participating in vaginal intercourse, the cutoff is 20 days. For rectal tissue, which is the primary route for men having sex with men, as well as also for women, that could be the route of intercourse, so 7 days. And it's faster for rectal because these are oral regimens, so it goes through the mouth all the way through the colon. So it goes, because these are all regimens, they go to the site that's of interest immediately, whereas for cervicovaginal tissue, it needs to be absorbed first and go into the blood, and then blood needs to go to the vaginal tissue and transfuse for this drug to achieve concentration. So it's longer, it takes longer to get enough concentrations in the vaginal tissue. And we don't have any data in as far as penile tissue. Now, these are based on Truvada when it comes to Descovy, which was approved for PrEP in 2019. We don't really have the PK data, so it's not clear how long it will take. If we had to guess, it will probably be similar to Truvada, but the truth is that we just don't know. And as I mentioned before, Descovy has not been approved for heterosexual couples or people who inject drug. It just has not been studied. It has only been studied in MSM or transgender women. And of course, most recently, at the end of 2021, cabotegravir in long-acting was approved for pre-exposure prophylaxis. Now, because so here's the package, and it has one vial, so it only has cabotegravir in it. It does not have relpevirine. So relpevirine is only used with this when you have the full treatment. But for pre-exposure prophylaxis, it's only cabotegravir, so only one agent. Now, because it's a long-acting, it takes several weeks for the body to clear this. Some patients may have concerns about tolerability. So if somebody was to have a bad adverse effect to this, they will have that for several weeks. So there is an optional short-acting oral cabotegravir that they can try for 4 weeks just to make sure they don't have any adverse effects. But this is optional because it is extremely rare for patients to have intolerable adverse reactions to this drug, so that's optional. Just like the oral option, the time from initiation of PrEP with this regimen to protection is unknown, so it's not clear how long it would take. Now, because of the long half-life, there is this long tail of gradually declining drug levels. So if somebody wants to come off PrEP, then because of the long half-life, they're going to have the drug in their system for a long time, including once it goes subtherapeutic, they will have that subtherapeutic levels for a long time. So if they happen to get HIV infection during that time, they are at high risk of developing drug resistance. So that makes it tricky. When somebody discontinues this, it's probably a good idea to go on oral PrEP if they are to have some exposure to HIV. Of course, if somebody knows for sure they're not going to have exposure to HIV, it's not going to be an issue just discontinuing this. Now, let's look at the follow-up for monitoring. So it is recommended that for all patients to at least every 3 months to get the HIV testing, as I mentioned before, to make sure that if they test positive, they need to transition. This is primarily based on oral PrEP, so we're talking about Truvada and Descovy. So if they do test positive, they need to be transitioned to ART, and the HIV testing is a combination of antigen antibody and RNA assay, which I'll explain shortly. And then because of the risk factors for getting HIV and STIs are the same, so bacterial STI screening is also recommended. Now, it's recommended more frequently for MSM and transgender women, so every 3 months, whereas for everybody else, bacterial STI screening is recommended every 6 months. And of course, as part of these every 3 months, it's important to assess signs and symptoms of acute HIV, as well as side effect assessment, so we can manage side effects to improve adherence. There could be other reasons for non-adherence, so it's important to do a full adherence assessment and provide support to patients. And depending on what risk factors they have, it's also important to continue to assess those risk factors, because if they don't have those risk factors, then they may not need to be on PrEP continuously. So if somebody doesn't have those risky behaviors anymore, they can come off PrEP. And for people who inject drug, it is important to assess access to clean needles and syringe, and in fact, it would be important to provide to them clean needles and syringes, because if we don't, what ends up happening is that patients just share needles or use dirty needles that they find at various places. And of course, for women, it's important to do pregnancy tests. Now, if somebody is receiving tenofovir-based PrEP, it's important to assess renal function. If they are aged 50 years or older, or at baseline their creatinine count is less than 90, the renal function needs to be assessed every 6 months. Otherwise, if somebody is younger than 50, or if their renal function is greater than 90 at baseline, they can just be assessed every 12 months for renal function. And then every 12 months also, it is important to assess weight and lipid panel if they are receiving TAF. So TAF only, TAF specifically is associated with weight gain and dyslipidemia. So that does not apply to TDF. And lastly, evaluate the need to continue PrEP annually. For the injectable cabotegravir, which is injected every 8 weeks or every 2 months, again, at 1 month after the first injections, it's important to get HIV testing, as well as checking for acute HIV and assess risky behaviors. And then every 2 months, and the reason these are shorter follow-ups is because they match the time that the patient has to come back to the clinic to get the injections. So essentially, these are every 2-month injections. So if the patient is coming back to the clinic to get the injections, then there's opportunity to do HIV testing and make sure that they have access to clean needles and all the other things that we need to do. So at every 4 months, it's important to get STI screening for MSM. Every 6 months, STI screening for everybody else. Every 12 months, assess desire to continue injections. So in other words, PrEP is kind of like birth control. So, people don't need to be on it for forever, but as long as they have risk of being exposed, the same way that, for birth control, as long as somebody doesn't want to be pregnant, they receive birth control, but it's not for life. The same applies to PrEP. As long as somebody is at risk of being exposed to HIV, they can be on PrEP. But if those risk factors go away, for example, let's say they stop injecting drug, or if they change their partner and they're no longer being exposed to a sexual partner with HIV, then they no longer need to be on PrEP. And that's something that needs to be assessed every 12 months. Now, those follow-ups, it is recommended to do both antigen antibody testing and RNA assay, and that's important to reduce the risk of false negative and false positive. So if both of them agree, the results of both of these tests agree. So either if both of them are positive, you assume the patient has HIV. If both of them are negative, HIV negative. But if there is discordant between the two tests, either one or the other is positive and negative, then a new plasma specimen needs to be sent for RNA assay specifically, and then based on that confirmation, it's either HIV positive or HIV negative. Now, when it comes to adherence assessment and support, there are several approaches that can be effective. One is educating patients about their medications, helping them anticipate and manage side effects, asking about adherence success and issues at follow-up visits. So, for example, you can say something like, many people find it difficult to take a medicine every day. Thinking about the last week, on how many days have you not taken your medicine? So this is asking, well, first of all, you make sure that the patient feels safe. So by making it, non-judgmental, that this can happen to a lot of people. And then secondly, asking an open-ended question so the patient can open up about their adherence. And helping them establish dosing routines that mesh with their work and social schedules. And providing a reminder system and tools. addressing financial substance use disorder or mental health needs that may impede adherence, and facilitating social support. And of course, one counseling point is patients should be told to take a single missed dose as soon as they remember it, unless it is almost time for the next dose. If it's time for the next dose, they can just skip it and continue the regular dosing schedule. Please pause this video and review these key components of oral medication adherence counseling. Lastly, the Senate Bill 159 in California came into effect in July of 2020, and this is important because this new addition to the bill essentially lets a pharmacist furnish or dispense HIV PrEP as well as HIV post-exposure prophylaxis. In this part, I'm going to focus on the pre-exposure prophylaxis. And the bill says a pharmacist shall complete a training program approved by the board, which we provide that here in the school through this course. And then a pharmacist shall furnish at least a 30-day supply and up to a 60-day supply of PrEP if all of the following conditions are met. Now, this is slightly different than the guideline, because the guideline, which is in general for physicians, the limit is up to 90 days. For a pharmacist is up to 60-day supply, but at least a 30-day supply until, and this is essentially to link them to care so they can follow up with the primary care physician. Now, it is important before a pharmacist can furnish this to make sure the patient is HIV negative, and this must be based on blood, not the oral saliva test, and it must be within the past 7 days. No self-reported signs or symptoms of acute infection, no currently taking contraindicated medications, and the pharmacist provides counseling to the patient on the ongoing use of PrEP, which may include education about side effects, safety during pregnancy and breastfeeding, adherence to recommended dosing, and importance of timely testing and treatment as applicable for HIV, renal function, Hep B, Hep C, STIs, and pregnancy for individuals of childbearing capacity. And the pharmacist shall notify the patient that the patient must be seen by a primary care provider to receive subsequent prescriptions for PrEP, and that the pharmacist may not furnish a 60-day supply of PrEP to a single patient more than once every 2 years. And the pharmacist initiating or furnishing PrEP shall not permit the person to whom the drug is furnished to waive the consultation required by the board. So they cannot waive all of this information. You are required to provide all this education to the patient. We looked at CDC recommendations for HIV pre-exposure prophylaxis. Now, given an HIV-exposed patient, recommend appropriate post-exposure prophylaxis regimen or PEP. When it comes to post-exposure prophylaxis, there are two different guidelines. There is one that's occupational post-exposure prophylaxis or OPEP, which primarily refers to the healthcare setting. For example, if you get a needle stick. There is also non-occupational post-exposure prophylaxis, so things like sexual assault or unprotected sex or exposure to injection drug use. We will focus on non-occupational post-exposure prophylaxis. The recommendations are basically identical. So the post-exposure prophylaxis should be started as soon as possible. However, it should not be started beyond 72 hours. So it's only effective as long as it's started within 72 hours. And because this is post-exposure, so possibly the virus could be inside the patient's body. Therefore, as opposed to pre-exposure prophylaxis, which was just the backbone, the post-exposure prophylaxis includes the full treatment. So you need the backbone, which is typically tenofovir, desoproxil, emtricitabine, plus a third agent, which is either raltegravir or dolutegravir. And alternatively, this third agent could be darunavir boosted with ritonavir. So these are the agents that have been studied, so that's why we shouldn't use anything else. For example, bictegravir and elvitegravir have not been studied for post-exposure prophylaxis. So our options are raltegravir and dolutegravir and darunavir. Another thing to note is that raltegravir twice a day dosing is studied for post-exposure prophylaxis. So the more recent formulation of raltegravir that's dosed once daily should not be used for PEP. It's only for treatment of HIV. And lastly, the new formulation of tenofovir TAF, which recently got the indication for PrEP, it's not indicated for post-exposure prophylaxis. So it has not been studied for PEP as of yet. So therefore, we have to use Truvada as the backbone plus a third agent. And of course, we don't use a bacavir-based backbone because there is no time to check for HLA-B 5701. We gotta start treatment within 72 hours. And the treatment is for 28 days. So this is fixed. So we just treat for 28 days. And hopefully after 4 weeks, the patient will not develop HIV infection. As always, it's important to provide education to the patient regarding adverse effects, as well as checking for potential drug-drug interactions. So basically, when someone gets exposed to the virus, of course, if the the risk is negligible, the PEP is not needed. But if there is reasonable evidence that the patient has been exposed to the HIV, if it's been more than 72 hours since exposure, then PEP is not recommended. We'll just wait to check for HIV, and if the patient develops HIV, you just treat the HIV because post-exposure prophylaxis will not be effective. But if it's been less than 72 hours, now post-exposure prophylaxis will be very effective. So there's potential to prevent HIV infection. Now, if we do know the source, so for example, if somebody had unprotected sex with someone, we can potentially test the source and see if they're HIV positive or HIV negative. So if someone happens to be HIV positive, then definitely we start post-exposure prophylaxis. And then if we don't know the source, for example, in cases of sexual assault or rape, we just have to go case-by-case basis. In most cases, we would actually go ahead and do post-exposure prophylaxis. Now, when it comes to monitoring for post-exposure prophylaxis, so if we do know the source of the infection, it's helpful to check for HIV to see if the source actually had HIV, because if they didn't, then post-exposure prophylaxis will be unlikely. And then some of the other things that can be transmitted in the same way, such as Hep B, Hep C, and some of the sexually transmitted infections like chlamydia, gonorrhea, and syphilis. These should be also tested in the source. And then in the patient who was exposed, also they need to be tested for HIV, as well as for Hep B, Hep C, and sexually transmitted infections. And then because we are to start post-exposure prophylaxis, we also need the serum creatinine and liver chemistries, because we're going to use Truvada, and depending on whether you use raltegravir, dolutegravir, or darunavir, these will be used for monitoring. And then in 4 to 6 weeks, we check for HIV again. That will be at the end of treatment. So treatment is basically for 4 weeks or 28 days. So we check one more time, and then one last time we check HIV 3 months after exposure, just to make sure that post-exposure prophylaxis actually worked. So if this one comes out to be negative, we know that post-exposure prophylaxis worked and the patient did not get HIV. On the other hand, if this tests positive, then unfortunately the patient is diagnosed with HIV, and then they need to go on lifetime treatment. Now, one scenario where you would need to check HIV 6 months after exposure, if someone also test positive for Hep C, because it's been shown that people who have Hep C while they were exposed to HIV, the seroconversion, meaning development of antibodies, will be delayed. So you would be detecting that at 6 months. So that's the only time you would get it at 6 months. And of course, in females of reproductive age, we also check for pregnancy at baseline and then at the end of treatment. And that's really just to make sure that we do a better job of follow up, because if the patient does develop HIV, they can the patient can transmit the virus to the fetus. Now, depending on the situation, on how the patient got exposed to the virus, for example, if it was unprotected sex, and if the patient has that risky behavior frequently, it might be a good intervention to transition from PEP to PrEP. So once we complete the 28 days of post-exposure prophylaxis, we can have a conversation with the patient if they think that they will continue the risky behavior after PEP. If the PEP was successful and the patient did not develop HIV infection, then upon a negative HIV test, we can actually give patient PrEP. So, depending on whether you gave patient PEP formulation, either raltegravir with Truvada or dolutegravir with Truvada or darunavir with Truvada, this will be for 28 days, and then after 28 days you just give them Truvada as PrEP, and they will be on Truvada as long as they continue the risky behavior. Now, the Senate Bill 159, SB 159, that will be effective July 2020, expanded services of pharmacists to HIV PrEP as well as HIV PEP. So pharmacists can furnish HIV post-exposure prophylaxis starting July of 2020, as long as the pharmacy gets a training in it. So typically, I imagine a 1-hour CE will be required, or maybe if more CEs. But most importantly, the pharmacists can furnish a complete course. Now, they don't specify what complete course is, but they do say that they will be referring to the CDC non-occupational post-exposure prophylaxis guideline, which would define the complete course as 28 days. So what they really mean here is a 28-day course of post-exposure prophylaxis. And then they follow the same requirements as the CDC guidelines. So it has to be within 72 hours of exposure. And just like PrEP, the pharmacist is required to provide full counseling to the patient, including transition to PrEP. And the patient may not actually waive this consultation. So it's actually required. We looked at CDC recommendations for HIV pre-exposure prophylaxis as well as CDC's recommendation for post-exposure prophylaxis. Now, given an HIV patient case, evaluate and manage common drug-drug interactions.
So when it comes to the pharmacokinetic boosters, we have cobicistat and ritonavir. Cobicistat is actually not an HIV drug, so it has no activity against HIV. Ritonavir itself is a HIV protease inhibitor. However, we actually don't use it for its protease inhibition because we use a lower dose. It's such a potent inhibitor of these enzymes that we actually use it at suboptimal doses. So the doses, 100 milligram of ritonavir is not enough to be active against HIV, but 100 milligram is such a potent inhibitor of these enzymes that we actually use it to boost the concentrations of other protease inhibitors. So you can see there are some differences between the two. One thing in particular about cobicistat is that it can actually artificially increase serum creatinine, and that's because it actually inhibits some of the secretion of serum creatinine. So it really does nothing to the GFR. So obviously, integrase strand transfer inhibitors are primarily the first-line agents that we use for treatment of HIV. So currently, we have 4 on the market: raltegravir, dolutegravir, elvitegravir, and bictegravir. Elvitegravir is the only one that needs to be taken with food. They're pretty much all taken daily. Up until recently, raltegravir had to be taken twice a day, but now there's a new higher dose of it that you can actually take once a day. In particular, elvitegravir and bictegravir are actually substrates of 3A4. So elvitegravir itself actually needs to be boosted. So cobicistat will inhibit CYP3A4. So as a result, you will need less of elvitegravir. So the pills will be smaller, and also with the half-life that's a little shorter, 13 hours, you can still dose elvitegravir once a day because of that pharmacokinetic booster. Now, bictegravir, although it is a substrate of 3A4, it does not need boosting. So you need smaller doses of bictegravir, so 50 milligrams. So also the pill is smaller than elvitegravir. So that's another reason that boosting was not needed for bictegravir, because for 50 milligrams the pill was small enough, whereas elvitegravir, even with a booster, you still need 150 milligrams. So if you didn't have that booster, you would probably need several times 150 milligram. So when it comes to drug interactions, elvitegravir will have the most, not because of elvitegravir itself, but because it has to come with cobicistat. So cobicistat will cause a lot of drug interactions, whereas the rest of them don't have a pharmacokinetic booster. One thing that bictegravir and dolutegravir have in common is that they both inhibit OCT2, and one thing that's important is metformin is actually a substrate of OCT2. So OCT2 is it's actually its function is to actually secrete metformin. So because they inhibit, you will see metformin levels increased. So that would be a significant drug interaction, because you will see a lot of diabetic patients on metformin. Bictegravir also inhibits MATE1. So let's look at some clinically significant drug interaction. So all integrase strand transfer inhibitors will interact with cations like antacids. So any polyvalent cation containing like aluminum or calcium, they will actually bind to integrase inhibitors and will prevent their absorption. So for that reason, anything that contains a polyvalent cation should be avoided, or actually should be spaced out by 2 hours. So 2 hours before or after you give integrase strand transfer inhibitors. So all 4 of them will interact with antacids, or not just antacids, anything that has. So if you were giving calcium pills, or anything that has a polyvalent cation. One thing that bictegravir and dolutegravir have in common is that they both will interact with metformin and dofetilide. So when it says avoid, when I say avoid, I actually mean contraindicated. So dofetilide is actually contraindicated with bictegravir and dolutegravir. Metformin is not a contraindication, so you just adjust the dose. Now, there's a really good chance that cobicistat may also interact with dofetilide. However, it's not in the package insert at the moment. So they may just not have studied it, but be careful with cobicistat and dofetilide. I didn't see it in the package insert, but I suspect cobicistat will also interact with dofetilide. Bictegravir is also contraindicated with rifampin, because rifampin is a strong inducer of CYP3A4 and bictegravir is a substrate, so rifampin should be avoided. With elvitegravir, it's recommended to avoid anything that's a substrate of CYP3A4, like these statins are actually substrates of CYP3A4, and because cobicistat is a strong inhibitor, it's actually contraindicated to use these two. It is okay to use atorvastatin. The same goes with salmeterol. And then rifampin, of course, is a strong inducer of CYP3A4. That actually, because you actually need a pharmacokinetic booster for elvitegravir. So cobicistat is a strong inhibitor of CYP3A4, and rifampin is a strong inducer. So you should it's actually contraindicated to use rifampin because it will mess up elvitegravir levels. The same with some of the anticonvulsants like phenytoin. They're also inducers. So pretty much most inducers of CYP3A4 should not be used with elvitegravir because it needs help from a pharmacokinetic booster. And then, of course, because of cobicistat, patients use caution with hormonal contraceptives because cobicistat can inhibit and cause failure of hormonal contraceptives. When it comes to protease inhibitor, of course, these are the three most common protease inhibitors, and of course they're boosted. And the reason they can be boosted is because they're all substrates of 3A4, so they're not usually renally cleared. And for non-nukes, so efavirenz and rilpivirine are the two common ones that you use. Etravirin actually, for food, you should take it after each meal. Food can actually increase etravirin by 50%, so it's recommended to take it after meals. It doesn't necessarily mean empty stomach, but it just says take it after meals rather than with food. Now, these are all CYP3A4 substrates. One thing that's special about efavirenz is that it's actually an inducer of CYP3A4. So you will also see a lot of drug interactions with efavirenz. So for protease inhibitors here and rilpivirine, here are some clinically significant drug interactions. So again, because protease inhibitors are boosted, you should avoid substrates of CYP3A4. So here are the three statins that are substrates of CYP3A4. Atorvastatin also has a separate mechanism of clearance, so it's not as strong. So it's only listed here for because it's in the package insert for atazanavir, boosted atazanavir, but it's okay to use atorvastatin with darunavir. There are also hepatitis C protease inhibitors that are also substrates of CYP3A4, so they should be avoided because these are boosted and the boosting will affect the levels of hep C drugs. And the same can be said about salmeterol. Now, atazanavir and rilpivirine both need an acidic environment for absorption. So with atazanavir and with rilpivirine, it's you should actually avoid proton pump inhibitors because they need the acidic environment.
Let's take a look at some common drug interactions. When it comes to drug interactions, you will see that the majority of significant drug interactions are with boosted regimens, so either boosted protease inhibitors, so atazanavir, darunavir, and lopinavir are boosted with ritonavir or with cobicistat. And of course, elvitegravir is the only integrase strand transfer inhibitor that's boosted with cobicistat. And because these pharmacokinetic boosters are CYP enzyme inhibitors, they lead to significant drug interactions. Now, when it comes to corticosteroids, you will see that beclomethasone, which is available as both the nasal formulation as well as inhalation, is pretty much safe to take with any regimen. Now, for the sake of this discussion, we're going to ignore any topical formulations. Budesonide is available as inhaled and intranasal formulation, but it is also available as systemic formulation, so it can be taken orally. And you will see that it's contraindicated with any pharmacokinetic booster, so it's not, it should be avoided with the boosted PIs as well as elvitegravir. Now, it does interact with efavirenz because efavirenz is an inducer, but it's not really contraindicated. So you just have to monitor and make adjustments to the dose of budesonide. Now, systemic dexamethasone itself is a inducer, so it can actually reduce the concentration of protease inhibitors and elvitegravir. So it should be monitored and dose adjustments must be made. But the interaction is significant with rilpivirine, so it actually should be avoided with rilpivirine. Now, fluticasone is available as inhaled and intranasal, and both routes are actually contraindicated with boosted PI or boosted Elvitegravir. Mometasone as well is available as intranasal or inhaled formulation, and both routes are contraindicated with cobicistat and with boosted protease inhibitors. Prednisone is systemic, and it does interact, but it's not contraindicated with boosted regimens and efavirenz. Salmeterol is inhaled. While it does interact, it's not contraindicated. So anything that's yellow, it potentially interacts, but it's not contraindicated, whereas the red boxes are contraindicated and should be avoided. And the green, of course, means no significant interactions. Now, triamcinolone is also available as inhaled or intranasal. It does interact with boosted regimens and efavirenz, but it's not recommended. Of note, triamcinolone, fluticasone, and budesonide are also available over the counter as intranasal formulations. So as pharmacists, it is very important to provide education to patients who can easily walk to the shelves and grab any over-the-counter products. So if they are on these boosted regimens, it's important to let them know that fluticasone and budesonide over the counter are contraindicated, and triamcinolone would be the safer option should they need intranasal corticosteroids for seasonal allergies, for example. So that's an important education to provide to patients. Now, when it comes to some of the cardiovascular agents, of note, amlodipine and diltiazem are two commonly used calcium channel blockers. Because they are also substrates of CYP enzymes, they do interact with boosted regimens as well as efavirenz. However, they are not contraindicated, so you just have to monitor the patient's blood pressure and heart rate with diltiazem and make adjustments to the dose of amlodipine and diltiazem based on their blood pressure and heart rate. Okay, so we are here at the local Walmart. We're gonna go check out the pharmacy. You know where the pharmacy is? Okay. Okay, so I'm looking for over-the-counter allergy relief. Okay, so they have Flonase and Nasocort. Oh, Cecilia, you're here. I have a HIV patient who's taking boosted regimen. They want Flonase. What do you think?
Flonase. No, that's a terrible idea. Flonase will interact with boosted regimen and non-nukes.
Oh, what should I do then?
Go this way. Nasocort.
Nasocort?
Yes.
Oh, thank you.
I'm here to help you.
When it comes to hormonal contraceptives, CYP3A4 has a role, so both efavirenz and ritonavir can affect the levels of progestins. So because of that, it is recommended to use additional contraceptive methods when the patient is actually taking efavirenz or boosted regimens. So with these, they're not really contraindications, but it's important to let the patient know that these can make hormonal contraceptives ineffective or less effective. So they should use alternative methods of contraception. So primarily with boosted and efavirenz. So as I mentioned before, with statins, Basically, the three statins that go through CYP3A4 are listed here, but atorvastatin in particular doesn't primarily depend on 3A4. So, historically, atorvastatin was considered a drug interaction with anything that affected 3A4, but nowadays we have data that atorvastatin is not as much affected. So, the only exception is that with atazanavir, atorvastatin is actually contraindicated. But with with darunavir, for example, they just recommend the maximum dose. But it's okay to use atorvastatin with darunavir. So these two contraindicated with anything that has cobicistat or ritonavir. So anything that's boosted.
We looked at pre-exposure and post-exposure regimens. We evaluated drug-drug interactions. Now, given a patient case where an adult patient with HIV is experiencing intolerable adverse effects, recommend appropriate management.
So when it comes to adverse effects, of course, our the newest nukes actually are generally well tolerated, whereas the older nukes had severe toxicity. So mostly because of mitochondrial toxicity. So zidovudine, which is one of the oldest ones from the 80s, and we still use it because it's available in IV formulation, and also we have significant data in pregnancy. So it has all of those terrible side effects that all the old nukes have. Now with abacavir, of course, you can have hypersensitivity reaction, so it's important to check for HLA-B 5701 polymorphism. TDF is nephrotoxic and bone mineral loss, so osteotoxicity. And TAF is an improved version of TDF, so it's well tolerated. So it can still cause some nephrotoxicity and bone mineral loss, but it's not to the extent of TDF. And emtricitabine can also cause hyperpigmentation. So when it comes to, so you can see they have looked at the bone mineral density over 48 weeks in different studies, and they can see how much bone mineral density loss has occurred once the drugs have been studied. So you can see that most bone mineral density loss occurs in the studies that actually has TDF. So tenofovir disoproxil fumarate, you can see all these yellow or orange, I guess, all these orange lines. There's significantly more bone mineral loss, whereas when we change that TDF to TAF, TAF is significantly less bone mineral loss compared to the other formulations that have TDF. Now, with the integrated strand transfer inhibitors, which are first-line recommended regimens, are pretty well tolerated in general, and so they are both effective and well tolerated, and they actually do pretty well against resistance. So that's why they are recommended first-line. One thing about raltegravir, it can actually increase creatine phosphate kinase or CPK. With elvitegravir, you can actually see proteinuria. And when it comes to boosted protease inhibitors, darunavir is well tolerated. Lopinavir is a relatively older protease inhibitor, so you will see more adverse effects, especially some changes on EKG. Atazanavir can actually cause jaundice, so in a lot of areas they actually call it bananavir. So bananavir because it's common to see jaundice in patients. So because of that, because of toxicity, actually, these two agents are not used as much anymore. Darunavir is better tolerated. So should we need protease inhibitor, typically darunavir is the drug of choice. And the reason we would need protease inhibitor because they actually do significantly better against resistant HIV. Even compared to second generation integrase inhibitors. So they are, typically when patients experience treatment failure because of resistance, protease inhibitors are drugs that we go to. But because of these side effects, and also drug interactions, we don't use them initially in someone who's treatment naive. So with the non-nukes, the two that you will commonly see are efavirenz and rilpivirine. Rilpivirine is actually well tolerated. The reason we don't use it first line is because for rilpivirine to be effective, the CD4 count needs to be greater than 200 and a viral load less than 100,000 at baseline to start it. So that's, considering how many other options we have, that's a lot of things to look at. So rilpivirine is not first line anymore. But efavirenz actually has CNS toxicity. So one thing that a lot of patients will complain about is vivid dreams. So they could be so much that that the patient will actually stop taking it. Now, for a lot of patients, these are supposed to go away after 2 to 4 weeks of treatment. But if they persist after 4 weeks, then it's a good idea to switch them to something else, because as time goes on, this can lead to non-adherence. Another thing that's important is CNS toxicity can also cause suicidal ideation, and that's actually the primary reason efavirenz is not first line anymore, because it actually increased the odds of suicide attempt and completion. As I mentioned earlier, cobicistat can actually block MAT1 or MAT1, and MAT1 can actually secrete creatinine. So by blocking this, it artificially artificially increases the levels of creatinine in the blood. So it doesn't really change GFR, but it can artificially increase serum creatinine. So here are some numbers. So cobicistat, because it increases serum creatinine, if you're using Cockcroft-Gault equation to calculate creatinine clearance, you will automatically get the number that's 15, can be up to 15 milliliters per minute lower. So now rilpivirine and dolutegravir also have some, they also can increase serum creatinine, so keep that in mind. So when it comes to different regimens, it's important to consider renal function. So this is creatinine clearance cutoff. So for elvitegravir, cobicistat, emtricitabine, whether it's with TDF. So this is Stribild. So with Stribild, it's actually, so if the patient creatinine clearance is less than 70, it's not recommended to initiate it. So in order to start Stribild, which has both cobicistat and TDF, which can affect creatinine clearance, it has to be greater than 70. Now, if it's somebody's creatinine clearance is 72, and you started and it goes to 65, you can continue. But if it goes below 50, then it's recommended to discontinue, and that's in the package insert. Now, with darunavir, cobicistat, and TDF, the cutoff is also 70, but they don't really say anything about once it goes less than 70. So once it goes less than 70, you have to discontinue it, because it doesn't have a statement about going less than 50. But with Stribild, definitely you can continue until it's less than 50. Once it's less than 50, you discontinue. But with darunavir, cobicistat, once it's less than 70, you discontinue. So you can see the cutoff for some of the other agents. So for most of them, whether it's TDF or dolutegravir, it's 50. If you use the TAF formulation, anything with TAF, whether there is cobicistat or not, with TAF the cutoff is 30. So definitely that improved it. And most recently we have the combination that doesn't have the backbone, so there is no TDF or TAF. So we have a dolutegravir with rilpivirine, and renal function doesn't matter. So for these combination, you can use it at any creatinine clearance. So should someone need a reason to change their ART, whether it's because of intolerable adverse effects or because the renal function got worse or whatever the reason, there are some basic principles that should be considered when switching, in patients who are virologically suppressed on the current regimen. So one thing, so although they may be virologically suppressed on the current regimen, it's important to review their past history to make sure they didn't have resistance to regimens in the past. So if they did have resistance in the past, you want to avoid those agents. If they have had resistance in the past, it's important to consult an expert. Generally speaking, switching within the same class is not an issue. So, if someone didn't tolerate efavirenz and you were to switch them to rilpivirine, it will be okay. However, if switching between classes is a little more tricky, so you really have to know what you're doing. So, for example, if someone is on a protease inhibitor and you're about to switch them to a non-nuc, so if someone is on darunavir and you're about to switch them to efavirenz, you have to be careful and make sure that it will still be susceptible to efavirenz because you're switching between class. But generally speaking, it is possible to switch between classes if you don't have reason to believe that it will be resistant.
We looked at CDC recommendation for HIV pre-exposure prophylaxis and post-exposure prophylaxis. We evaluated and managed common drug-drug interactions, and we looked at patients who experienced intolerable adverse effects and how to manage them. Now, let's educate an HIV patient on important lifestyle modifications.
So now that we have really good potent HIV regimens, our HIV patients are actually living longer. So now we have been able to actually study and see, how does aging affect HIV patients? Because before, patients would die within 10 years of having HIV. So we couldn't do these studies before. In fact, you can see that in the 1990s, a lot of patients would die as they aged, like very quickly. And then, throughout 2000s, as we improve treatment, more and more patients are actually living longer compared to the non-HIV infected patients. And this was a study from Denmark. These comorbidities include hypertension, which is the most common one, but also you can see HIV patients are more likely to have MI. So when you compare, so orange is HIV infected, blue is HIV uninfected. You can see significant difference in MI, but also peripheral arterial disease, when you also CKD. So factors related to non-AIDS comorbidities, obviously aging is a huge part of it, but unfortunately we cannot do anything about aging.
And then the other thing is that chronic HIV infection will lead to chronic inflammation. So even in patients who have undetected viral load, there will be chronic inflammation. And as we know, inflammation can lead to fibrosis and multi-organ damage over many years.
There's ART toxicity, so whether it's TDF causing bone toxicity or nephrotoxicity, that's something important for the pharmacist to monitor. So if someone is losing bone density, you may want to intervene and switch them from TDF to TAF or other regimens that are not as toxic.
Another thing is that these patients, based on their risk factors, they could also be co-infected with other viruses such as hepatitis C.
Of course, obesity, exercise, and diet and smoking are the most important lifestyle modifications. And the reason is HIV patients are at higher risk of having cardiovascular disease. And because of that, these are things that are associated with cardiovascular disease. So it is extremely important to provide education to HIV patients who would benefit from weight loss. It's important for them to exercise, and it's important to also give them education about diet. In fact, most HIV clinics actually have a dietitian as part of the team, so that they actually get comprehensive education about diet. So dietitians have an important role in the care of the HIV patient. Now, when it comes to, so you can provide education for weight loss, exercise, diet, and smoking. The most important out of all of this is smoking.
So these things can lead to inflammation, dyslipidemia, insulin resistance, and decreased physical functioning, which over time can lead to end organ disease such as cardiovascular disease, CKD, metabolic syndrome, and neuropsychiatric dysfunction. Again, most ART agents are generally well tolerated. When it comes to NRTIs or NUCs, older NRTIs are more likely to cause dyslipidemia. Newer NRTIs are less likely to cause dyslipidemia. TAF in particular can increase triglyceride LDL and HDL. But overall, the ratio of total cholesterol to HDL is not changed. Newer NRTIs are unlikely to cause insulin resistance. Of course, we have discussed that TDF can, reduce bone mineral density, and TAF significantly less likely to do this. And when it comes to bone marrow suppression, this specifically happens with older NRTIs. So zidovudine is one of the older NRTIs that we still have on the market. And then with cardiovascular disease, abacavir is associated with MI, which is kind of controversial because FDA has not found a correlation between abacavir and MI, whereas some observational studies have. When it comes to integrase inhibitors, the boosted elvitegravir is also likely to increase triglyceride, LDL, and HDL, but it doesn't really cause anything else. Protease inhibitors, especially the older ones, were associated with dyslipidemia. Darunavir and atazanavir are, they can still increase triglyceride, LDL, and HDL, but not as much as some of the older protease inhibitors. And then with NNRTIs or non-NUCs, efavirenz in particular can slightly increase triglyceride, LDL, and HDL. So in the 2018 American Heart Association guidelines for cholesterol management, they actually added HIV patients as one of the risk factors for having atherosclerotic cardiovascular disease. So they did say that for patients who are 40 to 75 years of age with LDL 70 to 189, and this is in the absence of clinical atherosclerotic cardiovascular disease, in the absence of diabetes. So if someone doesn't have those things and LDL is 70 to 189, if you calculate the 10-year risk score and it's 7.5 or higher, then someone who is also infected with HIV, they can benefit from statins more. So if you had a patient who you weren't sure if you should start a statin, but they had HIV, so that can push you toward actually prescribing a statin because they're more likely to benefit from it. And of course, these are the statins that are recommended, which I'll explain in a minute. So the following year, in 2019, the American Heart Association actually released guidelines for cardiovascular disease in people living with HIV. So this is HIV specifically, and they had two types of recommendation. One was lifestyle optimization, and one was pharmacoprevention of cardiovascular disease in HIV. So at the top of the lifestyle optimization is smoking cessation, followed by limiting alcohol consumption, increasing physical activity on a regular basis, and of course they refer to the 2018 guideline for dietary guidelines, which emphasize vegetable, fruits, legume, healthy protein sources, whole grains, and non-tropical vegetable oils. And they wanted patients to limit intake of sweets, sugar sweetened and artificially sweetened beverages, as well as red meats. When it comes to pharmacoprevention, in general, there are 4 groups of patients who benefit from statin therapy. And this is similar to non-HIV infected patients, but this guideline, this algorithm is specific for HIV patients. So for secondary prevention, is basically someone who already had an MI, stroke, or peripheral arterial disease. So someone who already had an event, you want to prevent another event. So that would be secondary prevention. And these are patients aged 21 or older with clinical atherosclerotic cardiovascular disease, and they will be considered high risk. So they need high risk approach. The rest of the groups who need a statin would be primary prevention. So these are people who have not had an event yet, but we want to prevent them from having an event for the first time. So it would be, so the second group would be patients with a very high LDL, so LDL 190 or higher. That would be high risk. The third group would be the diabetic patients aged 40 to 75. And then the last group would be people without diabetes, without high LDL, and without clinical atherosclerotic cardiovascular disease. And in these patients, we calculate atherosclerotic cardiovascular disease. And they did have 3 different calculators that you can use. So the most famous one that's commonly used nowadays is the 10-year atherosclerotic cardiovascular disease risk score. And they did say that you can, if it's 7.5% risk or higher, they will be high risk. If it's less, it will be low risk. Now, they do say that these calculators did not have HIV patients in them. And in general, HIV patients are 1.5 to 2-fold. They have 1.5 to 2-fold greater risk of having cardiovascular disease. So whatever you calculate, it's more likely higher in people living with HIV. So for example, if you calculate it to be 6.5 in a HIV patient, it will likely be more than 7.5, so you can consider them high risk. And in high risk patients, basically you go to this green area. Of course, you start with lifestyle modification, so such as smoking cessation, and then you want to use a lipid-lowering drug therapy, statins primarily. Whereas for patients who have low risk, statin therapy may not be indicated. And then when it comes to smoking, they looked at smoking cessation in people who are infected with HIV and compared that to people who had smoking cessation but they did not have HIV. So here on the y-axis, we're looking at the incidence of myocardial infarction, and on the x-axis, we're looking at the time in years. So you can see that the lowest risk of MI is in patients who do not have HIV and who never smoked. And when you compare that to HIV positive patients who never smoked, you can see this is pretty similar. So this slightly higher in HIV patients who never smoked, but still higher in HIV positive patients. Now when you compare to people who were previously smokers and did not have HIV, so that's even a history of smoking increased the risk of MI more than HIV did. But when you compare former smokers who actually have HIV positive, you can see this is significantly higher. So a combination of HIV and smoking is very detrimental as far as incidence of MI. And you can see the maximum risk of MI is in patients who are HIV positive, who are current smokers. So, smoking cessation, you can see that it will reduce the rate of MI significantly. To make things worse, about half of people living with HIV in the US are current cigarette smokers. And cigarette smoking is not only a risk factor for MI, but also a risk factor for stroke, for lung disease such as lung cancer, emphysema, and infections such as bacterial pneumonia, tuberculosis, and pneumocystis jirovecii pneumonia. Now, one of the problems with smoking cessation is that for majority of patients, it's difficult to achieve smoking cessation. In fact, the rate happens to be in the long term about 12 to 15%, at least in the studies. So if you encounter patients who are unable to quit despite intensive intervention, including pharmacological intervention, an alternative goal for smokers who cannot quit is cutting down. And basically what that means is that reducing the number of cigarettes per day is actually has been shown to have survival advantage compared to heavier smoking. And studies have shown that most smokers living with HIV can successfully cut down their tobacco use within 24 weeks. So, when you provide education to patients, you can talk about weight loss, you can talk about statin therapy, you can talk about diet and exercise, but the number one recommendation to discuss with patients should be smoking cessation, or at least cutting down on cigarettes per day. We looked at CDC recommendations for PrEP and PEP. We evaluated and managed drug-drug interactions. We looked at patients who experience intolerable adverse effects and how to manage them. And we educated the patients on importance of lifestyle modifications. Now, when indicated, let's recommend immunization to patients living with HIV. Generally speaking, the immune response in people living with HIV is significantly lower. Even when the patients are receiving ART, the CD4 T lymphocyte remains significantly lower compared to people who do not have HIV. Even the B cell activation will be impacted by HIV, and this is most likely due to the persistent inflammation. Even in patients who have undetectable viral load, this inflammation persists. And in general, recommendations for vaccinations are similar in HIV patients, with the exceptions of a few contraindications in HIV patients, especially with CD4 count less than 200, because they will be severely immunocompromised, especially when it comes to live vaccines. In general, the data for vaccine effectiveness in HIV is very low, which has led to under-vaccination in people living with HIV. So we need to do a better job of vaccinating HIV patients. All right, let's take a look at immunization recommendations for commonly encountered vaccines. So in one column, we are looking at healthy people, in other words, people who do not have HIV. And then in the middle, we have people living with HIV, but in general, they are divided into two groups. One that are really immunocompromised, so that's defined as either CD4 count less than 200 or CD4 count less than 15%. And of course, less immunocompromised would be CD4 count of at least 200 or at least 15%. So first we have the inactivated influenza vaccine, which is recommended annually for everyone, including people with HIV. So, inactivated influenza vaccine is recommended for people living with HIV, regardless of CD4 count. The live attenuated vaccine, of course, is not recommended for everyone who is healthy. It is only for age 2 to 50. And it's even then it's alternative because of lower efficacy. But when it comes to HIV, because this is a live vaccine, it's actually contraindicated in HIV regardless of CD4 count. And this is the only one that's contraindicated in CD4 200 or higher as well. Next, we have pneumococcal vaccine. So most recently, we have PCV 15 and 20 on the market. So either of them are recommended for people living with HIV. However, if somebody gets the PCV 15, it's also recommended for them to get the PPSV 23 8 weeks later. If they do get the PCV 20, there's no need for PPSV 23, and that is including once they turn 65. So, once somebody gets PCV 15 or 20, they're good for life. They don't need to get anything else once they turn 65. The same is true if they get PCV 15 and they get PPSV 23 before age 65, then they do not need to get it again once they turn 65. Now, with hepatitis A and B, HIV is actually an indication to get these vaccines. In addition to HIV, in general, men having sex with men and people who inject drugs, as well as those who have cirrhosis and who are homeless. So if any of these apply to the patient, it's recommended to get the hepatitis A regardless of CD4 count. And of course, hepatitis B vaccination is extremely important in these patients because co-infection with HIV and hepatitis B virus actually increases the risk of mortality compared to having either infection as a mono infection. So, patients with HIV, Hep C, people who inject drug, cirrhosis, and men having sex with men, any of these are indications for getting the Hep B vaccine. For meningitis, we have the meningococcal vaccines. We have two different formulations, one that has serotypes A, C, W, Y, and then we have a separate one that has serotype B, and there is one under development which will combine all 5 serotypes in the same vaccine. For people living with HIV specifically, serotypes A, C, W, Y are more likely to cause meningitis, so it is recommended for these patients to complete a 2-dose series 2 months apart, and then because these people will be living with HIV for life, they do need to get the booster every 5 years. Whereas Men B is not really recommended specifically for HIV. However, if the patients have other indications such as asplenia or complement deficiency, then they qualify to also get Men B. For HPV or human papilloma virus, just like the general population, it is recommended up to age 26. And then between age 27 and 45, it is a shared decision making. For varicella, it's important to note that it is a live vaccine, so it is contraindicated if the CD4 is less than 200. So if the patient has severe immunodeficiency, it is contraindicated to give varicella vaccine. For people with CD4 greater than 200, it's a shared decision making. So, it's something that the clinicians should discuss with the patients to basically discuss, risk versus benefit to see if the patient is willing to take this. And lastly, we have zoster vaccine recombinant, which is an inactivated adjuvanted vaccine, and it is recommended in routinely after age 50, so age 50 years and older, regardless of CD4 count. Now here's back to this slide for pneumococcal vaccine. So this is HIV infection is one of the indications under immunocompromised persons. As I mentioned, regardless of age, once somebody is age 19 or older, assuming they have not received PCV, any PCV vaccines as part of childhood immunization, they do need to get either PCV 20 or 15. If they get 20, that's it. If they do get PCV 15, they need to get 8 weeks later, they can get PPSV 23. Now, if they happen to have already received PPSV 23, they need to wait at least 1 year since PPSV 23 and get either PCV 15 or PCV 20. Okay, but ideally they should get the PCV first and then PPSV 23. That concludes this presentation.